And welcome to the fourth webinar of SOGO. As in the beginning I had said about SOGO activity, there was a query last week that what is SOGO? I just want to expand on that. SOGO is an academic body aimed at promoting the activities of education research in urologic oncology. Now, it has a specialty that it includes all the three disciplines of urology, medical oncology, and radiation oncology. So there is a common platform for all this. This body was conceived. This whole fact was conceived in January, and we were to hold the first conference in February, and the lockdown came in. So therefore, it is still under the process of under the Society of Registrars of the Society, and by next month, I suppose we should be in a position to get through that. Meanwhile, we continue our academic activities. First, we had 2 sessions on kidney. Third session was non-muscle invasive bladder cancer, and we are talking today on a minimal invasive bladder cancer. I welcome you all, and let's hope for a great show today. Over to Rakesh. Thank you.
Thank you, Dr. Jagdish Kulkarni, sir. Thank you, Dr. Jagdish Kulkarni, sir, and good evening to all. At the outset, I would like to thank the SOGO committee, Dr. J.N. Kulkarni, sir, Dr. Sudhir Rawal, and Dr. S.K. Raghunath, Dr. Girin Kumar, to give me this opportunity for conducting this meeting on muscle invasive bladder cancer. And it gives me immense pleasure to invite all the esteemed international and the national faculty, plus all our urology colleagues who will be at the audience to listen to this meeting. Unfortunately, due to some unavoidable circumstances, Dr. Hassan, our international faculty from Mansoura, won't be available. His presentation would be taken care of by Dr. Rawal, sir. And everybody mentioned that it's an exhaustive meeting. There's a lot of topics are there, but muscle invasive bladder cancer is quite exciting. Plus, we wanted to cover the complete spectrum, right from the radiology to radiation, everything, even the chemotherapy aspects, all for the benefit of the postgraduates and all our young urology colleagues who are there. So I request everybody, all the speakers, to limit their time, as I've given the instructions to how to go about, so that we maintain a good time limit and give opportunity to all speakers. So this program will be coordinated by me and my friend and colleague, Dr. Sanjay Adla. So the first 2 sessions will be coordinated by Dr. Sanjay. So I request Sanjay to take over from here and start the meeting. So thank you, everybody.
Good evening, everyone. As the director for this first 2 sessions, the only objective of me is to keep a check on the time. Yes. I would request Amitabh Singh from Rajiv Gandhi Cancer Institute to moderate the first session and invite the speakers, following which you can also invite the experts for the comments, please. Thank you very much. Over to you, Amitabh.
Thank you, Dr. Sanjay. So, good evening, everyone. Welcome to the first session of today's webinar. In this webinar, we will try to cover radiology, pathology, and neoadjuvant chemotherapy of the bladder cancer. And today we have eminent speakers for this session. And after finishing this session, we would like to have comments from our experts, senior faculty. So first of all, for the first talk, I would like to request Dr. Palak. She is a radiologist from TMH Hospital, Mumbai. Her topic is imaging in bladder cancer. Dr. Palak, over to you.
Thanks, Dr. Amita, for the kind introduction. I'll just share my screen. Okay, so talking of imaging in bladder malignancies, what are the options that we have when we look at imaging? So we have the ultrasound, the CT, along with CT urography, MRI with its urography counterpart, and a PET CT scan. So sonography will be the modality with which the patient comes to you with an ultrasound report. And usually it's a 2D mode or a Doppler mode. So by 2D mode, we mean it's just the black and white images, and the Doppler gives you some color flow here and there. So what is the purpose? Patient will come to you generally with an ultrasound report. It is a screening for indication of hematuria in our patients. It is used to rule out other causes, to detect if there is a lesion or it is just cystitis or some other etiology. and for ruling out any other absence, and loco-regional assessment if you do find the disease. So for example, this is a 2D ultrasound image where we see the bladder, and this is a bladder mass. So this is a nice gray soft tissue, which we call as this would be an iso to a hypoechoic soft tissue. It has an echogenic rim, which is a little brighter than the rest of the lesion. And this is the bladder wall with its normal artifacts, which is shadowing, which is seen along its lateral wall. And what we see here, the brighter or the wider area is called as the posterior acoustic enhancement. So when we look at a homogeneous structure or a fluid, we see posterior enhancement on ultrasound. What we see here on the right is that there is some amount of vascularity. So is it a bladder clot? I can ask the patient to move and see if it is mobile enough and falls down. If it doesn't, it remains stationary. We always put a Doppler flow and see if it is vascular. So this is not a clot and this would be a mass. Now, this is another example where we have like a papillary projecting tumor excrescence into the bladder lumen. We see the bladder wall here, and there is a little hyperplasia of the bladder wall. So this is very nicely seen, a hyperplastic bladder wall with a lesion in the bladder. And in another section, we see this soft tissue here. So this patient is going to have a focal extravesical infiltration, although there is a lot of intraluminal projection, and we didn't really expect it when we saw this section. So this reinforces the fact that an ultrasound is very subjective. If I only see this part, I'm going to miss out this part. This is one of the biggest differences between a cross-sectional and an ultrasound, where in a cross-sectional imaging, the images are static. You can see them. In an ultrasound report, you are left at the discretion of the radiologist who has reported and what they felt was best seen. The other issue with ultrasound is, so this extravesical infiltration which is seen here, if it was at this point of the bladder, I would have missed it. So there are certain hidden areas where you may not always have a good visualization of your lesion. Coming to a CT scan, so the utility would be to confirm that yes, is there a lesion, to differentiate between hemorrhage and a lesion which is enhancing, because on the plain scan both appear whiter. All right. It is used to assess frank extravesical extension for the adenopathy and the loco-regional staging. So this, for example, this is the bladder, hardly any urine seen here on the ultrasound, and is largely filled with a soft tissue. This is the Foley's inside the bladder. And when we throw some color around, we see vascularity along the periphery, and there is just some necrotic area seen in the center. When we move to the CT scan, there is a large amount of bladder which is not involved, unlike what I showed in the ultrasound image. This would be the urine in the bladder. The enhancing whiter area is the bladder mass, and this little gray area is the hemorrhage, which is not enhancing but whiter than the urine. So on a plain scan, this whole thing would be of the same shade, but on post contrast, I can see different shades, and we can differentiate between the two components. Now, I do see something over here, not sure, and the beauty of a CT is a reformation. So it is not just perpendicular, cornal, sagittal, or axial. I can swivel around the images and try to get to see whether there is extension. And there is this little focal extravesical extension, which is quite convincing in this particular projection. So we would report it as focal extravesical extension. For that matter, there was a little extravesical extension here posteriorly also. Coming to MRI, so it offers an excellent contrast for assessment of bladder wall invasion. So there are several studies which suggest that an MRI can be used as a valuable imaging tool in determining the presence of bladder invasion in organ-confined bladder cancer. So what is the role? When we talk of an MRI, we would talk of the sequences, the nodal assessment, the lesion assessment. The most common site is the obturator nodes in a bladder cancer involvement, and they are beautifully seen on an MR. 16% of the patients have nodes above the aortic bifurcation, and 8% have presacral adenopathy. This anatomical delineation is beautiful on an MR. Since pelvic nodes are taken care of during surgery, it is more important to identify the nodes in the common iliac chain and in the retroperitoneum. So how would you compare an MR and a CT? If you have a patient with a deranged renal function, then definitely the choice of investigation would be an MR, because in the absence of contrast, CT doesn't give much information. In the absence of contrast, yes, an MRI can be done. You have 4 factors that can evaluate a bladder tumor, and you can do a MR urography. The dynamic contrast enhanced feature will be missing, but that doesn't affect the management to that extent. So yes, an MRI gets a tick there. Radiation, we know the accuracy of T staging is way higher with an MRI, and lymph node staging is fairly equivocal on both sides. So then came up the concept of VIRAS, which I'm sure all of you all know about. And it basically swivels around a T2 weighted, a diffusion, and a dynamic contrast image, where the objective was to have a standardized approach. So what I talk and what you understand from my report should mean the same language. And so it stemmed from the BIRADS, and we are all so familiar with the PIRADS in the prostate. And then comes our VIRAS. So VIRAS is relatively recent. If for you to understand, PIRADS 1, 2, 3, 4, 5 will tell you whether there is significant cancer or not. But a VIRAS 1, 2, 3, 4, 5 will tell you whether there is muscle invasion or not. So what you are talking varies with each RADS, and this is what is important for a bladder management. So comes in the VIRADS. So it is to suggest a risk of muscle invasion. The benefit is mainly for non-muscle invasive expected cancers. So this is how this is a bladder wall, and we have a bladder mass over here, and there is a stalk here. So in a very basic language, if this is going to be VIRADS 1, there is no invasion of the tumor into the bladder wall. VIRADS 2 is just a little larger one. The stalk disappears in a 3. In 4, the tumor is going into the muscle, and in 5th, it is gone beyond the muscle. So that is the VIRADS 1, 2, 3, 4, 5 very briefly. So I'll just show you 2, 3 images where this is a very beautiful scene, a small bladder lesion, and the stalk in the center, very nicely seen. The bladder wall is clean. It is totally not involved. It is seen here in different sequences on the T2 images. This is dark on ADC and bright on diffusion. So that tells us that, okay, this is definitely something which is going to be a malignancy in a high likelihood. This is the MR urography. MR urography is nothing. You do not give IV contrast to the patient. So when you have a patient with higher creatinine or deranged RFT, you ask for an MRI, plain MRI, non-contrast with MR urography. Wherever there is water in the body, it gets highlighted. So you will see some bowel fluid. You will see the ureters delineated unless there is peristalsis or narrowing. And we see the bladder over here, and the tumor is very nicely seen as a filling defect. This is another, so something like this would be very well seen on your cystoscopy also, and you may not need an MR, but well, the TURBT should preferably come after an MRI. So the MRI would first show you the lesion. But something like this, where there is like a multifocal lesion, and this is definite involvement of the bladder wall, and it has not gone beyond. But here I'm very certain. So even if the TURBT report was inconclusive, and the MR was on beforehand, it surely warrants for a re-TURBT, and there is a muscle wall invasion over here. This is frank extravesical infiltration, which is very easily and self-explanatory. So we spoke about the 5 VIRADS that we discussed. What is the validation of VIRADS in detecting the muscle invasion? So there are examples of 2 studies where they saw like 340 patients. Most of them were NMI BCs, and the sensitivity and specificity were 87 and 96%. For a score of more than equal to 3, which seems to be good. Another paper where they saw 231 patients, and to discriminate non-muscle from muscle invasive at an initial TURBT, they had a sensitivity and specificity of of a good 91%. Our experience was close to 95 and 85 respectively. For B1 and B3 lesions, we were very good. B4 and B5, sometimes we had an issue. So the best practices when we look at the guidelines. So now these are the recent most guidelines, and stage 2, they do suggest an abdominal pelvic CT or MRI if it is not done before. Same holds good for a stage 3 and a stage 4. They also recommend for an NMI BC as well as an muscle invasive bladder cancer. The EAU also suggests a very specific, yes?
Sorry for interrupting. The time is up, please.
Yeah, sure. So the EAU also recommends it strongly for an MRI. The proposed clinical impact is that pre-TURBT, MRI has its best value. You can use it for response assessment. Diffusion has the best feature. Then comes the dynamic contrast enhancement, then a T2. So each has its own descriptions, which I'll skip. And the last would be the role of PET-CT in bladder cancer. So because the dye is accumulated in the bladder and the lesion is also kind of hampered by it, it is not seen well. So what can be done to overcome this is adequate hydration, bladder irrigation, and forced diuresis with furosemide. So the benefit and the studies say that for detection of CA bladder, a PET CT is not of a great value, though it can be seen, but it is much more better for a metastatic evaluation and for loco-regional extent in advanced disease and for response assessment. So my just last case, like for example, this patient had a bladder tumor extending to the ureter, and this was a large tumor and enhancing component here on CT. Patient underwent neoadjuvant chemotherapy and the solid component has nearly almost gone. So there is a very good response, but there is a large amount of residual disease. But to get the functionality of how much is the activity of the cellular burden, the PET CT very beautifully shows the immense extent of residual uptake despite the decrease in the solid component of the mass. So it has a very good value in post-chemo assessments and metastatic diseases. My take-home points are that, of course, we need large trials to see where bladder and MRI bladder stands. And CT can be used for advanced disease, PET CT reserved only for metastatic cases and post-chemo assessment. Thank you so much.
Hello. Thank you, Dr. Palak, for summarizing your talk beautifully. So we are running short. So I would like to proceed for the second talk. I would like to request Dr. Santosh Menon. He is head of histopathology department from TMH Mumbai. So he will be talking on pathology in muscle invasive bladder cancer, urothelial and non-urothelial variants. Dr. Santosh Menon.
Thank you, Amitabh. Am I audible?
Yes, sir, definitely.
I'll share my screen. So thank you, Rakesh. Thank you, Dr. Kulkarni, and thank you, Dr. Raval, for having me here. Is my screen visible?
Yeah. Yes, sir.
Yeah. So I have been asked to speak on pathology of muscle invasive bladder cancer. I'll just highlight and touch upon the difficulties in diagnosis, which is the first point to call it a muscle invasive. Talk a little about the variant histology, because most of the variant histology patterns are muscle invasive disease, and a little about ancillary techniques, including IHC and molecular for these variants. So what are the pressure points in pathology in muscle invasive? So in a TURBT sample, there are issues in reporting of muscle invasion. What is muscle invasion? What constitutes? One pathologist calls it muscle invasive, the other does not agree with him. How do you recognize variant histology and LVSI? Can you pick up on TURBT? And is there some ancillary help to pick up muscle invasion? In cystectomy, it is the sampling of post-TURBT cystectomy samples, extension of the tumor, and lymph node. I won't be going much into detail of cystectomy. I'll be concentrating on TURBT. So as you know, the salient points in pathology report of TURBT includes the diagnosis, the grade, whether the muscle is present, and whether it is muscle invasive. And you have to distinguish between what kind of muscle are you looking at. Is it muscularis mucosa versus muscularis mucosa versus a propria? One outright clarification I would like to make for the clinicians here is that almost all muscle invasive bladder cancers are by default now considered to be high grade. So very occasionally you may find, very rarely you may find a variant called the large nested variant, which is low grade looking but is invasive. But for all practical purposes, once you get a diagnosis and report of muscle invasive, you have to by default take it that this is a high grade disease. The first question when a report says muscle invasion is not seen, supposing you get a report saying that muscle invasion is not seen, what you should ask the pathologist, is the muscle present and invasion absent, or is the muscle sampling is itself inadequate? So that's the first question a urologist should ask the pathologist. And as a pathologist, it is my prerogative to tell you whether the muscle is present and the muscle is not invaded, or the muscle is present or it is or the sampling is inadequate. So this clarification has to be very clear in the report by the pathologist. And if you have done a large volume TURBT and you are thinking that's going to be high grade and the pathologist has reported high grade but has not completely embedded the tissue, you should tell your pathologist that please go and completely embed the tissue, because you need to be sure about muscle invasion. So once your high volume TURBT comes as high grade, you have to completely sample to look for muscle invasion. So as a pathologist, what are my problems? The tissue is usually very fragmented, TURBT tissue. There is site of anatomical variation. So in the trigone, you may not find muscularis mucosa. There is directly tumor which is sitting on the detrusor, so it's very close to the detrusor. So the chance of a tumor at the trigone being muscle invasive is very high. There is something called hypertrophied muscularis mucosa, especially after BCG therapy, and in bladder where there is obstruction, there is hypertrophy of the muscularis mucosa. and this starts looking like detrusor muscle. And obviously, due to crushing and cautery, you may find it may be difficult for the pathologist to call this. So this is just a picture to show that this is a tumor, and these are the pink fibers of the muscle which being invaded by this tumor. There is some help in IHC. There is a marker called smoothulin which marks the detrusor muscle, which can be used. We also use desmin and vimentin to highlight the detrusor muscle, and we can by this help we can sometimes, but not always, use, and it's of limited use in diagnosing muscle cancer. Coming to divergent differentiation variant histology, as high as 20% of urothelial cancer can show divergent differentiation, and the point of telling you this is about 60 to 80% of these variant histologies may be muscle invasive at presentation. So why do we recognize 44% of they may be missed? So 44% of these are misdiagnosed. Most of the guidelines, NCCN, MD Anderson, EAU, all of them state that micropapillary, plasmacytoid, and sarcomatoid, these are the variants which are very aggressive. They may have already invaded the muscle. Even if the pathologist says Stephen, the clinician should be aware that these may be actually T2 in this. So what are the different divergent differentiation urothelial cancers? Squamous, micropapillary, plasmacytoid, these are the common ones. You may find adenocarcinoma, small cell carcinoma, and sarcomatoid are the other common ones which come into practice. So these are some pictures. This is squamous carcinoma showing squamous pearls. It is the commonest one. It is very commonly muscle invasive, and the importance in clinical parlance is that they are responsive to PD-L1 therapy in many of these cases. They are diagnosed by the characteristic keratin and the IHC for P40 and CK56. This is a picture of micropapillary. What is the importance, clinical importance of micropapillary? It is more advanced stage with nodal involvement in almost all cases. Early cystectomy is propagated for these, and some of the T1 tumors may even have to undergo NACT, as these are mostly nodal mets that have mets at presentation. A characteristic is the positivity for HER2 new protein in these tumors, and trastuzumab has been used to treat some of these patients. GATA3 is a characteristic marker for urothelial cancer, and CK56 or high molecular weight is also positive in these. Nested variant, it's a very, very banal looking or a very, very benign looking tumor with very low grade nuclei, but it may invade deep into the muscle. You can see the picture here that this tumor is invading deep into the muscle, even though it looks very, very low grade on. So this is a separate variant or a variant histology which should be picked up by the pathologist. Plasmacytoid tumor, we have seen quite a lot of them. They are characterized by high stage peritoneal mets. They go to the stomach, to the duodenum. So the metastatic sites are very, very peculiar. And if you do a cystectomy for these patients, the cut margins of the ureter and urethra may be positive in these. And the characteristic is the loss of E-cadherin on immunohistochemistry in these patients. So this is a picture to show plasmacytoid. Small cell, I'm sure everybody has come across them. They're very, very aggressive tumors. They're almost always muscle invasive with lymph node positivity, and etoposide-based chemotherapy is necessary. They are picked up by the characteristic histology as well as synaptophysin and chromogranin positivity. Another very difficult area in muscle invasive bladder is when the tumors are situated at the bladder neck and the base of prostate. So is it a prostate cancer or a bladder cancer? That's a very important question in practice. So this is a very poorly differentiated tumor which came at the bladder neck, and we use a panel of IHC markers to distinguish prostate from urothelial. This is a common practice which comes, and the most important markers are PSA, P63, NKX 3.3, 3.1, which comes positive in prostate, and GATA3 is a very, very nice and important marker for urothelial differentiation. So this is a panel of markers which your pathologist can employ to distinguish between prostate and urothelial at the bladder neck when they encounter poorly differentiated carcinoma. A quick brief overview of molecular pathology in muscle invasive bladder cancer. They help in prediction as well as prognostication, and it is the way forward into the future. All of you know that the low grade pathway is the FGFR3 pathway, and the high grade or the non-papillary pathway is through the P53 mutated pathway. When it comes to pathology, they're basically classified into basal and luminant tumors and the P53-like tumors. So I want you to remember these three terms: basal, P53-like, and luminal, because basal and P53-like tumors are mostly muscle invasive. If you look at this picture, the yellow one is a tumor which is more than PT1. So most of the basal as well as the P53-like tumors would be muscle invasive at presentation. And so they're likely to be MIBCs at presentation, basal-like and P53. And we can pick them up by doing a battery of markers like GATA3, P53, CK14, and this can help in prognostication. Also, these subtypes, they have a different response to chemotherapy. The P53-like is a non-responder to chemotherapy, whereas the basal-like respond better compared to the P53-like in chemotherapy. So I'll just skip this, and the take-home messages from my talk are that MIBC may be difficult for a general pathologist to diagnose, and sometimes you have to have that experience to differentiate between muscularis mucosa and muscularis propria. What is the muscle being invaded to call it? A variant histology is routinely missed. About 40% may be missed, and they are very important because they are mostly muscle invasive. So you have to create awareness. GATA3 is a very useful marker for urothelial differentiation, and IHC is a must when you have a neck of bladder tumor, poorly differentiate to differentiate between urothelial and prostate cancer. And molecular pathways and molecular subtyping is a very promising way to tailor disease management in the coming future. Thank you very much, Amitabh.
Thank you, Dr. Santosh. So you have summarized beautifully, and you have covered your talk within 8 minutes. So I'd like to thank you. So okay, for next talk, I would like to invite Dr.
By Rakesh to be within time.
Thank you, sir. Thank you, sir.
So for next talk, I would like to invite Dr. Amit Rotham. He is a medical oncologist from Manipal Hospital, Bangalore. So he will be speaking on the neoadjuvant chemotherapy in muscle-invasive bladder cancer, whom to give and what to give. Dr. Amit Rotham, over to you.
Good evening, everyone. Thank you, Dr. Amitabh. Thank you, Dr. Rakesh, for having me here. So my topic is neoadjuvant chemotherapy, and let's go ahead. So why do we do neoadjuvant chemotherapy in bladder cancer? It has become a standard of care for the last few years, and we believe we can downstage tumors. But more important that is, we believe once the bladder cancers have invaded the muscle, they have become systemic diseases. And so there's micrometastasis all over. And this micrometastasis is controlled by doing neoadjuvant chemotherapy, and that can improve our survival. And also, we believe we can downstage and get pathological CR in certain group of patients. And if we get path CR, we know these patients can have a potential to cure. So these are reasons why we do neoadjuvant chemotherapy. And this was the first major trial which we saw. This was an intergroup trial published 7 years back, where we looked at that time, the standard of care that was doing cystectomy for muscle-invasive bladder cancer, and randomizing it to chemotherapy followed by cystectomy. Now here the chemotherapy used was the MVAC regime, which is a standard MVAC, which is methotrexate, vinblastine, Adria, cisplatin given day 1, day 15, day 22, repeated every 28 days. Now standard MVAC was kind of a regime which was preferred by all the medical oncologists for many years, but this has changed now. But this was the trial which used standard MVAC versus followed by surgery versus surgery alone. And what we saw, a clear improvement in overall survival. A median survival of surgery alone was 46 months, and a median overall survival of MVAC followed by surgery 77 months. A clear significant improvement in overall survival when we did neoadjuvant therapy followed by chemotherapy. We say we get a median of 2.5 years improvement, which is amazing to see in this setting. What we also saw from this neoadjuvant data was that if you give neoadjuvant MVAC, you got a chance of 38% getting pathological CR. And if your patients with pathological CR, if you followed them long time, their 5-year overall survival was 85%. And 5-year survival of patients who did not receive path CR was much lesser. So not only were we improving overall survival by giving neoadjuvant chemotherapy, but we were also trying to prognostify our patients and tell them who could be very high risk and who could be a kind of a patient who would do well in the long run. As medical oncologists, if you ask me, MVAC is not a regime we are very happy with, and we don't like MVAC at all. So in the stage 4 setting, we saw the comparison MVAC versus gemcitabine cisplatin. Now, in this phase 4, in the stage 4 disease, we have clearly seen gemcis and MVAC are equal in efficacy, but toxicity of gemcis is much lesser than MVAC. And lot of us have moved to gemcis regimes in stage 4 disease. But this has also gone into a neoadjuvant setting, and gemcis has also become a standard of care in neoadjuvant setting, though there's not been a direct comparison trial of gemcis versus MVAC in the neoadjuvant setting. This is a meta-analysis which looked at all the trials of neoadjuvant chemotherapy, and clearly they show that at 5 years, we have a 5% improvement in overall survival if you look at all the trials together. Again, as I told you, MVAC is not a very comfortable regime, but in the last few years, we have a modification, and that is called dose-dense MVAC or accelerated MVAC, where you're giving all the drugs as day one, and with growth factor support, you're repeating this every 2 weeks. Now, the advantage of this is you're actually able to reduce toxicity by doing dose-dense MVAC, and this we have seen in our clinical practice also. You're not repeating the drugs at day 15, day 22, and what happens is the toxicity actually gets better. Your neutropenia could be an issue, but giving growth factors takes care of that. Now, this trial, a very phase 2 trial, small data, but clearly showed that in 44 patients, by doing dose-dense MVAC, you had a pathological CR of 38%. And what it also showed that is patients who got pathological CR, you have again a very good relapse-free survival and good overall survival. If your patients didn't get path CR, then they did not do so well. There was another trial, again a phase 2 data set, by different investigators looking at dose-dense MVAC, again looking at the same thing. When you gave dose-dense MVAC with growth factors, in this trial, 26% patients got pathological CR. And again, those patients with pathological CR did well. Now, all these trials were looking at taking tumors from CT2, T3, T4, and N1 disease. If you put down all the data sets which you have together, what you're seeing with neoadjuvant chemotherapy, you can get a pathological CR of somewhere about 38 to 40%, depending on what regime you use. But what we see is, in spite of not achieving path CR, if your disease is less than PT2, you still fare well in long term. But if your disease is more than PT2 residual, then your survival is poor. So clearly what we're seeing, 5-year OS in this data sets, PT2 less than PT2, 5-year overall survival was 90%. But if you have more than PT2, the 5-year overall survival was quite dismal. It was only 37%. We keep saying cisplatin is the main drug, whether we use MVAC or whether we use GemCis or whether we use dose-dense MVAC. But we know 30 to 50% of patients will not be eligible for cisplatin. And these are the criteria for cisplatin ineligibility. We say poor performance status, creatinine clearance less than 60, hearing loss, neuropathy severely, and heart failure patients. You can't give them cisplatin. So kind of the thought is, if you can't give them cisplatin, what would you do? Would you change the chemotherapy and go into any other regimen? Well, the guidelines are very clear. If your patients are cisplatin eligible, please give them GemCis or give them dose-dense MVAC, follow it up with cystectomy. If they are cisplatin eligible, don't use carboplatin, just go ahead directly with cystectomy. A few words about immunotherapy. We have seen 2 data sets recently of Atezo and Pembro, just giving 2 doses following with cystectomy. And what I saw, 40% path CR rate. And even with the Atezo trial, there was about 30% path CR rate. Very, very intriguing data, but we need long-term follow-up to understand how well these patients would fare. And as we know now, we are moving to a combination of immunotherapy with chemotherapy. This was one data set which said you start with neoadjuvant, Pembro, GemCis, 44% path CR rate. But again, whether this will become a standard of care, we'll know once all these clinical trials report. So my last slide, what do we do? This is the guidelines. If we have a stage 2 disease, if we have CT2N0, if we have CT3, T4, or a nodal positive disease, if they are systemic candidates, please give them neoadjuvant chemotherapy with cisplatin-based regime and then follow it up with surgery. If you can't use cisplatin and they are cisplatin ineligible, don't use carboplatin. Please go ahead with the surgery and then look at it at the next step. And lastly, is there a role of adjuvant chemotherapy? Very, very controversial, but I would say if you have not offered neoadjuvant chemotherapy and if your pathological comes as PT3, T4 or node positive, please offer them adjuvant therapy with cisplatin-based regimes. Thank you very much.
Thank you, Dr. Amit, for finishing within time. So I just thanks all my speakers, Dr. Palak, Dr. Santosh, Dr. Amit, for finishing their talks within time. And just now it's time to invite for the expert comments. We are having Dr. Santosh Kumar from PGI Chandigarh for the expert comment and Dr. Vineet Talwar from RGCI-RC. So first I would like to invite Dr. Santosh Kumar for his expert comment. Dr. Santosh Kumar, sir.
All 3 speakers have done wonderful job, but on the radiological imaging, I will say that Contrast enhanced ultrasound is one entity which is underutilized in case of bladder cancer. Sonic sulfur containing sonic particle when injected, it can show the vascularity of tumor, and whether the muscle is invaded by the tumor, the vascularity of the muscle part will be increased. And it also indicates that grade of tumor is also high when the reverberation is more. When you take it on graphic, we have done one study from PGI also. It has shown good sensitivity up to 70 to 80% of the cases in muscle invasion as well as lymph node involvement. Secondly, contrast multi-parametric MRI has got additional benefit when you can see there is the coefficient of diffusion is restricted in the muscle area, and there is diffusion is restricted in lymph node, which you can easily diagnose, as already explained by Dr. Palak. More than up to 90% cases you can diagnose whether cancer has invaded the muscle or it is metastasis to lymph node. Coming to the pathological part, some area which has not been discussed, that leiomyosarcoma of bladder, which is one entity which is also not uncommon, which has got also worse prognosis. Plasmacytoid variety, already one patient is admitted in our hospital at present. And papillary carcinoma, these are worse prognosis group, even rhabdomyoid sarcoma. So you don't lose the time. Just don't treat it same as the other TCC cases. You admit and operate on priority basis. Coming to the PD-L1 inhibitors should be done in biopsy specimen also, and number of lymph nodes must be evaluated in radical cystectomy specimen. Coming to the chemotherapy part, when we are giving chemotherapy is good for most of the cases of muscle invasive bladder cancer, but doxorubicin and cisplatin, when there is a cardiac problem is there, you must use with caution after cardiology consultation and after echo evaluation of the patient, and we should not wait. If there is delay in the evaluation of cardiac point of view, you should go ahead with radical cystectomy. Thank you.
Thanks, sir. So, Dr. Vineet, sir, your expert comment?
Yeah, Dr. Santosh has nicely summarized. I just want to add that in the histopathology, the role of GATA, which was told by Dr. Santosh, that is very good for differentiating the bladder neck tumors, where you have to differentiate between the bladder cancer and the prostate cancer. And as far as the chemotherapy part is concerned, the immuno-oncology drugs are definitely making a foray now into the muscle invasive bladder cancer, and till now they are becoming the standard of care as the time comes. But short of that, if you give gemcitabine or dose-dense MVAC, I think that should be the best choice in these patients. Over to you, Amita.
Can I just ask one question to Dr. Palak? This is from Mahesh Dehasa. He was inquiring about transvesical ultrasound scan and the usage of it, and where do you think there is a scope for it?
Yeah, so transvesical ultrasound, it is an entity which we do not practice with our institute, but it is very much there. It has two fallacies. One is when you look at the dome of the bladder and near the trigonal region, the area of coverage is not very good. Secondly, a lot of times you can have submucosal hypertrophy, which is why the visualization of the deeper muscle is not seen. So the muscle invasive component can be hampered if you have bladder cystitis or mucosal hypertrophy. So that is another limiting factor. And Dr. Santosh also very nicely brought out the summarization of this. Yes, contrast enhanced ultrasound is a very good modality. Just one caveat there is, if you have a small lesion which is in your window of ultrasound with your probe remaining there, the lesion can be well seen. If you have a large lesion, you have to go through and fro to the lesion. So you might miss out a muscle invasiveness at another point, because this is a very rapid turnover of the dye, and then it goes off in circulation. So if it is a large tumor, to look at muscle invasiveness might get difficult. It is good for smaller lesions. Thank you.
Dr. Palak, Yeah, one more question is there in the
Sure.
chat box. Given a choice, which is preferable, whether CCT or MRI in a patient with normal serum creatinine?
MRI, but I wouldn't say always MRI. The question should be in which situation. If you're looking at a local disease, more confined disease, please go ahead with an MRI. If you're anyway suspecting you have an advanced disease and you want to look at the nodes and grossly large disease, directly go ahead with a CCT. And MR then becomes more expensive. You're not looking at muscle. You're directly going to now jump to neoadjuvant CT. So that's what is different.
Thank you. Sanjay, two, three more questions are there. Can we take it up?
I think Dr. Sanjay needs to be told he needs to unmute himself.
Okay, then I'll ask the question. There are three more questions. It's directed to Dr. Amit. With neoadjuvant, if patient receives PT0, can he or she avoid cystectomy?
Answer is no.
That's a very controversial question. We say no.
Yes. So from the surgical side, I think Sanjay can take up. Sanjay?
No, like because even the T0 patients, around 15% of them still have recurrent disease at some point in the future. So it's not that 100% of them are cured. And if that is the state, even after removing a cystectomy, even after doing a cystectomy, definitely you got to be doing it. Just one question to Dr. Amit. How many cycles is the standard neoadjuvant chemotherapy, sir?
So it depends on what you are following. If you're following dose-dense MVAC, you would give 4 cycles every 2 weeks.
Gemcitabine cisplatin?
Then you would do 3 cycles.
3 cycles. Thank you. I think we have covered.
One more question, Dr. Amit. Last one, Sanjay. What is the role of adjuvant chemotherapy in a patient who has received NSCT and underwent cystectomy and did not achieve a pathological CR?
No, as of now, we don't have data. Anyone who's got neoadjuvant chemo, they would not receive adjuvant chemo.
Okay.
Thank you.
Thank you for having us. Thank you.
Okay.
Can I ask one question, sir? Dr. Sanjay?
Yeah.
So do we have any experience of this viriates just to differentiate whether this patient require returbate or not? If there are suspicion whether the muscle is included or not, considering the combining the factors or this finding of the viriates and pathological finding from everyone. Did you get my question?
Dr. Palak can take this question.
Yeah. So, we have seen cases where a lot of times a TURBT report doesn't mention the muscle and that indicates a re-TURBT test because the answer is not given in the TURBT sample. But a lot of times there's samples from outside. But when an MRI is done, the MRI very beautifully shows us the lesion most of the times. The problem is the incidence is lower and we are still not in a system to do a lot of pre-TURBT MRIs. It is best done before a TURBT. So if we have more data validated, it would be better. But I would suggest, yes, it can change and it can help in further management.
So if you would like to do MRI, then what is the time limit you have to wait for after getting TURBT? Like for 4 weeks, 6 weeks?
Yeah, so it is usually about 4 to 5 weeks at least. And if it's just a Foley's catheter insertion and no other treatment done, then we wait for 3 days for some amount of cystitis to settle down. But if a TURBT is done, then at least 3 weeks is the minimum period suggested. But once a TURBT is done, then it is the sensitivity goes down.
Okay. Thank you very much, Dr. Amitabh. We'll move on to the next session. I'm going to request. Thank you all. I'm going to request Dr. Vivek Venkatramani, consultant in Nanavati Hospital. Vivek, you can take over and invite the faculty and the moderator and the experts, please. Thank you very much.
Thank you, sir. Good evening, everyone. Without further ado, we'll have our first talk. Dr. Ashwin Tamankar from Apollo Hospital, Navi Mumbai, will talk to us on ERAS and its applicability in the Indian scenario.
Good evening, everyone. Cystectomy stands as the complications and the readmissions after cystectomy stands as an Achilles heel for every one of us. And hence the ERAS pathway was introduced for cystectomy in 2013. They have given us about 22 principles, which span from preoperative, intraoperative, and perioperative care. I'm not going in details of each and every of these. These are widely available for us to read. The data which we have so far on this is somehow limited with the evidence of only 3B. But the encouraging fact is that in the recent years, the number of principles which are being utilized is consistently increasing. Simultaneously, approach for the cystectomy is, as in the robotic approach has been utilized as a pathway for ERAS as well, including the intracorporeal divergence, which is an encouraging fact. So the meta-analysis which we have tells us that the ERAS course over a standard pathway in terms of shorter length of stay, reduction in 30-day readmissions, but no difference in 90-day readmissions, reduction in the complications, but these are limited to only low grade, that is grade 1 and 2, and no difference in the higher grade complications, and reduction in the time for recovery of bowel functions. Understanding the concept of ERAS, there would be some problems with the GI, and these complications have been beautifully summarized by a group from Danishmend. So nearly 15% of the patients will still have some GI issues, including 11% ileus and 7% requiring NG insertions. The readmissions do happen in spite of using ERAS, and the main factors which are driving are age and Carlson comorbidity index. But if you can see, the majority of these are infective complications between 30 and 90 days. The quality of life scores are definitely better with ERAS at day 3, 7, and at the time of discharge in a randomized trial. Coming to the cost, nearly $4,500 are saved per procedure per patient when we are adhering to the ERAS principles as compared to a standard pathway. So I'll be discussing more about the issues which we routinely face when we are trying to adhere to the principles of ERAS in Indian situation. So 82% of the panel are using still the same thing. The advantage being in a day or two, we can test the urine for the fact is majority of the diabetic patients who have gastroparesis because of the neuropathy, they might require these preemptively to reduce the ileus and nausea vomiting. Goal-directed fluid is a gold standard, obviously, to reduce the bowel edema. Transesophageal Dopplers are must, but majority centers in India may not be having that. The alternative which we use actually is euvolumic fluid restriction with or without vasopressors. Pulse pressure variation guided fluid administration with a threshold of around 12% is an entity established in anesthetic armamentarium, and your anesthetist should actually utilize this into the routine practice. Epidural again is a debate for open surgeries. Obviously, there is no confusion. A thoracic epidural is must because it reduces chance of opioids, chance of post-operative pain, and it causes sympathetic blockade as well. But for robotic approach, the epidural probably can be skipped because the reason being the patients are relatively pain-free, and secondly, the peripheral vasodilation caused by epidural may lead to hindrance in the mobilization. Calorie calculation is often missed out by us. Nearly 900 kilocalories between day 2 to 4 and 1500 beyond day 4 are important. From anesthesia point of view, short-acting induction anesthesia and maintenance with Dexmed and oxygen air desfluorine mixture acts beautifully. Extended venous thromboprophylaxis, though we are utilizing it in our practice, we are generally limiting it only until the time of discharge. But extended prophylaxis is must for cystectomies, either open or robotic, and it is proven, especially for patients who have previous NSAT being a high-risk feature. Nearly 68% of the thrombosis generally happen after the time of discharge within 90 days. So that is an essential part which we are missing out upon. The anesthetist, whenever is evaluating your patient for pre-anesthesia checkup, probably should also encourage the patient for prehabilitation. He or she should optimize the patient completely in terms of smoking cessation, cardiopulmonary exercise, and nutritional optimization. Again, coming to the core surgical team, I call it Pandavas. It's a surgical team comprising of surgeon, a dedicated fellow, bedside assistant, prompt anesthetist, and a nurse practitioner who can look after the stoma and post-operative care. Probably a core team can have better results, and in fact, it is included or considered as a 23rd parameter of ERAS nowadays. Obviously, the audit is the most essential part of it. Once you actually sit down and jot down the details about your last few patients, then you'll understand how many principles you are actually utilizing into your practice and what is the potential scope of improvement. Quick overview about the data which we published with Dr. Gagan Gautam. We actually skipped initial 30 cases as a part of initial learning curve and analyze the data for 35 cases. To our surprise, with the ERAS in these 35 cases, the figures are actually fitting into the very experienced group as per the Pasadena consensus panel, and there is apparent improvement earlier in spite of being into an interval of 30 to 100. The reason being completion of learning curve, utilization of ERAS protocol consistently with a great dedicated team. The similar numbers while putting into the table, comparing the robotic and open approaches with ERAS, I think we are doing fairly good in terms of length of stay, complications, and readmissions. So this was a question which was asked as recent as 2014. Are we ready for enhanced recovery after surgery for cystectomy, and can we not afford to implement these pathways? The answer is obviously no. So probably we have two options today: take a red pill and restart your cystectomist career with all the knowledge you have on ERAS to see the difference. And probably the simplest or easiest option is to take a blue pill and forget about everything today. So stress-free anesthesia, and so this is a summarizing slide: stress-free anesthesia and stress-free surgery, or in a way stress-free anesthetist and a stress-free surgeon is important. Just to reiterate the facts which we are slightly lacking in Indian situation: audit your patients, retrospect your own results, rehabilitate the patients, open and robotic cystectomy, do whatever you're doing best possibly, but try and optimize the number of principles which are using for your ERAS principles. Avoid epidurals for robotics if possible. Minimal invasive approach is always welcoming. NG tube has to come out on table without hesitation, which is still a matter of debate in India. Antibiotics you can continue for 24 hours in males, 48 hours in females, but not beyond that. Dedicated team for cystectomy is important. Try and pull out the drains early. A low molecular heparin has to go on for 4 weeks. Patient has to be taught about it, and they need to provided with a jab of 28 days in the form of pre-filled syringes. Focus on the calorie intakes and probably be vigilant about the red flags to pick up the early complications of GI related. That's it for today. Thank you.
Thank you very much, Ashwin, for that extensive talk. We'll now move to the second talk, which is on lymphadenectomy in bladder cancer, and Dr. Gagan Prakash will go ahead with that. Thanks.
Thank you. I hope I'm audible.
Yes, Gagan,
go ahead.
Yeah. Good evening, everybody. So I would be talking on the role of lymphadenectomy in radical cystectomy. I would like to acknowledge that majority of the slides I've got from Dr. Raghavan, Dr. Ravi, and Dr. Amandeep has worked on them. It was exactly half a century back when the concept of lymphadenectomy in cystectomy was first described. An interesting paper titled Regional Gland Dissection for Carcinoma of the Bladder, a technique for one-stage cystectomy, gland dissection, and bilateral ureteroenterostomy, published in the Journal of Urology with Ledbetter as the lead author. Over these years, the utilization of lymphadenectomy in cystectomy has drastically increased. If you look at it, it's gone up from close to 70% in 2004 to around more than 85% in 2013. The not so good part is that probably close to 10 to 15% of centers are still not doing lymphadenectomy, even in the West. And the barriers are likely, female patients, Afro-American race, low intermittent volume centers, non-teaching hospital, and the rural areas. So you would be discussing if there is any role of skipping lymph node dissection at all during cystectomy. What is the best yardstick, whether it's yield, density, or template? What are the randomized trials saying as of now? Approach, whether it matters, open, laparoscopic, or robotic, and what are the unanswered questions? The incidence of lymph node metastasis, as classically described in literature, ranges from 18 to 30%, and this differs based on whether the primary is a T2 or a T3, T4. Obviously, it's higher in T3-4 disease, close to 40 to 45%. We looked at the TMH experience, and in patients who had undergone a cystectomy with or without chemotherapy, and we consider ourselves a high volume center with a good extended lymph node dissection, even in them, around 11% of patients failed at the lymph node beds. And this is a paper under peer review, which should be out soon. Can we ever skip lymph node dissection during radical cystectomy? It has got two benefits. First is the staging one. So the current imaging cannot detect micrometastatic nodal disease. Pathological examination of nodes is the gold standard to detect nodal metastasis. And nodal status is a very important prognostic factor. Therapeutic benefit: patients with positive nodes can be offered adjuvant chemotherapy. There's one of the largest series of 2,000 patients which said that number of lymph nodes examined affects the survival after cystectomy, and extended PLND is associated with increased survival. Guidelines say that there is strong evidence that lymph node dissection has to be performed. It is an integral part of radical cystectomy. All the guidelines mention that. So there's absolutely no debate about whether a PLND should be performed or not during radical cystectomy. If at all, you have to think of, some rare instances, some patients where you're doing a cystectomy for BCG refractory and MIBC, although even this is kind of controversial. And in the setting of palliative cystectomy, maybe it can be skipped. Yield, density, template. We have heard these three terminologies. Which is the best yardstick? So there was a study based on radionuclides to see what's happening to the nodes. How do the nodes get affected in bladder cancer, where through a flexible cystoscopy, actually technetium was injected and then the nodes were mapped. Two large series. One has mentioned 16 nodes as one of the cutoffs. And what it says is that the survival, if it's more than 16 nodes removed versus less than 16 nodes removed, is different. And if you remove 20 nodes, then more than 80% of the positive nodes, which are likely to be positive, you would have covered. Another series from Dr. Her's group says that in patients for node negative disease, 9 should be the cutoff, and for positive, it should be around 14 nodes should be the cutoff. Extent, we know about limited, standard, extended, and super extended pelvic lymph node dissections. There have been various retrospective series where they've tried to see, depending on the extent, whether limited or extended or super extended, whether it affects survival, whether it affects recurrence or no. Couple of large series which I would like to mention. This was a collaborative work between the Cleveland Clinic and the University of Bern, and they compared limited versus extended PLND and found that extended was definitely better in all survival parameters. Another collaboration with the same university had with the USC, and over there they compared extended versus super extended. And in this case, they found that super extended does not offer an added advantage. Extended is probably good enough. All these retrospective series were combined to publish meta-analysis in the European Urology. 4 conclusions: any kind of pelvic lymph node dissection is advantageous over no lymph node dissection. Extended appears to be superior to limited or standard. Super extended does not offer extra benefit, and ongoing RCT should clear the uncertainties. Another meta-analysis, which in addition to confirming these findings from the previous meta-analysis, also said that the complications do not differ, whether you're doing limited or whether you extended. At the most, there might be a little more lymphoceles, but no major complications. The major complications are not more in the extended one. Lymph node density, a concept which again most of us are aware of, is the total number of metastatic nodes divided by the total number of nodes removed into 100. And there have been various cutoffs suggested for lymph node density. 20 is one figure, 11 is another figure put in literature. And we looked at our data from TMH and published it at AUA last year, where we found 15 to be a cutoff where, based on this cutoff, the survival differed. Randomized trials, where are we today? So, European Urology last year published a randomized trial from Germany where they compared 2 templates of lymph node dissection, and this was limited versus extended, and it found that extended lymph node dissection failed to show a significant advantage over limited lymph node dissection. There are some problems with this trial. So one of the biggest criticism was that they aimed to show a difference of 15%, which was a little overzealous. About 14% of patients had T1 disease, in whom there is very low risk of lymph node metastasis. Probably got diluted by this. Limited group had a median of 90 nodes. The arm which was actually limited group, even them they were removing around 90 nodes. Around 8 to 9% of patients in both groups had positive margins, which could have diminished any beneficial effect of the extended pelvic lymph node dissection. The other ongoing trial looks actually more promising because it has kind of addressed most of the criticism of the prior trials. So if you compare the second trial, which is yet to be published, which is from the SOGO group and is likely to be published in 2022, it includes only T2 and onwards patients. The difference which they are seeing is 10%. The effect size is 10%, not 15%. They've got a larger sample size as well. And they are also including patients which have received neoadjuvant chemotherapy. I believe the results would be more close to the real life situation. So with regards to the extent, what do the guidelines say? No conclusive evidence exists as regards the optimal extent of lymph node dissection. Does the approach, whether we are doing open, laparoscopic, or robotic, matter? For robotic, I think most of us who have been doing robotic surgery would agree that, and there is literature to suggest that it doesn't actually. The yield is the same, or probably in some instances even better than in open. In laparoscopic, there is some literature to say that probably open or robotic is better than laparoscopy when it comes to the yield. And even the 2 large randomized trial of robotic, which were the RAZEL and the CORAL, also did not find any difference in the lymph node yield. Does more dissection lead to more complications? The answer is no. Partial cystectomy, this we've spoken about the tetramodal bladder preservation therapy earlier as well, and this is a concept where even though we are doing bladder preservation, but there seems to be a role of pelvic lymph node dissection while doing bladder preservation. Technical aspect.
Sorry to interrupt.
Yeah, should be done in a minute. So the fossa or the triangle of Marseille is something which I just want to mention for the teaching thing. So take homes are when to perform pelvic lymph node dissection, all patients except in palliative setting, how much to perform bilateral extended, what all to remove, and how to remove either open or robotic, which is generally better than laparoscopic. What's unanswered, teaching techniques in low and intermediate volume institutes where lymph node dissection is not done adequately. Effect of NACT not very well known. Few patients who have retroperitoneal nodes which respond to NACT, what should be done, whether these nodes should be addressed at cystectomy or no, and the effects of BART, which Dr. Vedang would be trying. So yeah, areas where probably SOGO can contribute, and visual thinkings. Two things: one, we are not wearing masks over here, and the second, that I can see Dr. Raval is already contacting the SOGO mentor members to collaborate and find an answer to these questions. Thank you so much.
Thanks a lot, Gagan, for a very insightful talk. I see no questions on the chat box, so I think we can proceed. I'd request Dr. Jagdish Kulkarni to please introduce our international faculty and proceed with the talk. Thank you.
Good evening. Hope Dr. Rajputi is logged in.
No, excuse me,
of course,
sir.
Dr. Rajputi doesn't require introduction, but as the standard is, I have to say something about him. He's not logged in yet.
Yeah, we probably can wait because in San Francisco it is 5 a.m.
Oh yeah, so maybe
that may be the reason. He confirmed in the morning.
Yeah.
Rakesh?
He confirmed.
Yeah. So can we?
Yeah, sir. He confirmed in the morning to the mail, but probably I don't have his mobile number, so I have sent him a mail. Again, I have sent a mail. So we'll wait for his response, sir. We will move ahead with the further session.
I think so.
Later on. Any expert comments for this session, Rakesh?
We'll ask the experts to have the comments for this session.
Yeah, so first I'd request Dr. Mallikarjuna sir to please proceed with his comments on the two talks that we heard.
Well, I thought there's something more, another half an hour to listen before I can say anything else. Vivek, I thought it's a very short thing. I think Ashwin has summarized it very well regarding the ERAS protocol. It has become a part of life, possibly, if not to the completeness, possibly in a selective way, respect to their institutions. What has been working well, they have been adapting. What is not working well to their situations, they are not adapting. So I don't think there is so many things which have been listed into the protocol, but there is a selection involved and there is some element of bias involved onto the surgical aspect, surgeon's aspect also in adapting to it in toto. Whatever it is, I don't care whether you need to adapt in toto or less. If you are able to fairly, decently give a good result, I think that is good enough. What gets the benefit to the patient is fine. It has become, in fact, initially when it started off, it looked as if everybody is adopting it because everybody said that it is great. Whether they felt it is great or not was immaterial. Then over a period of time, though there was some amount of friction in between, whether it is correct or not, but over a period of time, they started realizing it, especially after the minimal invasive approach has set into it. It appeared that it is very good and possibly gives a better benefit to the patient and lesser amount of stress to you rather than looking at the Ryle tube aspiration every day, how much it has come, and clamping it now and then and seeing whether it is decreasing or not. I think it made it life simpler to measure the patient's recovery rather than the measurements which we need to do to measure the recovery. That's one good part of it. So the second part, as usual, Gagan was fantastic. He summarized 100 minutes data into 10 minutes and pushed it across. I think possibly I missed some slides, but one thing I ask Gagan, what do you think is a correct number? The two questions which I still ask you. What is the magical number which you expect as the lymph nodes which need to be taken out before you say? Because the data, what you said yourself, have got so much of variation in the various institutions itself is concerned. And number two, looking back, except that large data which suggests, population data which suggests that there was improved survival, which might not be related to the lymph node retrieval, how do you justify that it is going to give you a survival benefit by taking out a lot of lymph nodes. So see, the same thing happened with prostate cancer, and the same thing is getting back reversal. So are we giving any survival benefit by taking out too much of lymph nodes or taking that minimum lymph nodes? Can you justify it again?
Yeah, so the first question about the magical number. So I would say between 16 and 18 is what, based on whatever I have read. But there was a very interesting study which I did not present over here. What they did was that they looked at these three parameters: the lymph node yield, the numbers you've removed, the different surgeons who've been operating, and the different pathologists who've been looking at these lymph nodes. And they did it across oncology. So they did it for bladder cancer, they did it for stomach cancer, and they did it for, I think, breast cancer. And they found that all these three things, including the surgeon, including the packets which have been said, and including the pathologist, which is who's actually assessing, made a difference in all three different cancers. So possibly, it'll be very difficult to exactly say that this is the number and kind of generalize it for across the centers, because there would be variations based on the centers and based on the pathologist. The second thing, sir, even though we have one large randomized trial which says that extended does not have an advantage over limited, against many large retrospective series with their meta-analysis which says that extended actually have an advantage, what has happened is that because of this randomized trial, we've kind of got a little more confused. In terms of level of evidence, this is higher, but in terms of criticism, this trial does have problems. Particularly because they've included the non-muscle invasive also. The trial design had a problem. They had considered a 15% margin between the two groups, which was actually realistically very difficult to achieve in most studies. So the second, which is coming, the SOGO trial, is actually really something which I think, based on the design and based on the information which I have, I think that should be able to answer the question whether the extended is actually giving us a survival advantage of all three things: recurrence-free, disease-free, and overall survival, or no. So I think, we'll have to wait for an year or more than that. Thank you, sir.
We are going ahead with what was available all these days, and we were looking at the survival data and comparing it. Are we able to match to the data or not? We don't have a solid, anyway, I don't think it is ever possible to have a randomized data doing a lymphadenectomy, not doing a lymphadenectomy, and see what happens to the survival, which I don't think is possible in the near future too. There was one more question. I don't know if you have time, because there is no this thing. How do you feel? You see, every one of us we are looking into an Indian population with a lymph nodal yield in the Indian population. Do you think that there is a difference in the lymph nodal yield, what we get in Indian population versus the Western population, especially with lot of retroperitoneal lymph nodal inflammation, especially like filarial inflammation happening? You see, my experience wise, whenever we do a lymph nodal dissection in the patients with filariasis, with a history of filariasis, which I stopped doing it nowadays because the lymphatic leak problems were very high, the yield in one of the prostatectomies, which I did a bilateral simple lymph nodal standard extended pelvic floor dissection for prostatectomy, turned out to be 46 lymph nodes coming out. I just don't have a data to say that you'll have increased lymph nodes in patients with a filarial disease. But I don't know. There are some Sudhir and Jagdish should be able to put this thing onto it, because in these patients we definitely see a lot of lymph nodes. You do a nephrectomy also, you see a lot of lymph nodal disease which comes out in majority of our patients with donor nephrectomy. I'm not talking about malignancies. I'm talking about donor nephrectomy also. So that numbers are going to be much higher in Indian population or difference? We are not sure. You got a large data in TMH, so I thought you'll put a light on that.
So I think I would let, because both Kulkarni sir and Rahul sir are here, and this is something which is, a lot of experience would matter. But I'm sure this is something which from USI and from SOGO would be worthwhile looking at for Indian patients, very pertinent to us. Yeah.
If I have to just comment, well, of course, Dr. Skinner was a great proponent of, node dissection from the para-aortic region down to the pelvis completely. Of course, that was his story in 1986 I'm talking about. I recall distinctly, Badrinath Koneti had come out with a number of nodes at 13 nodes. And then he said, at least 13 nodes should be evaluated. Again, as you rightly said, this will go on. And the dust is yet not settled, perhaps, and the cows have already come home. And taking a clue from breast cancer, what happened the radical dissection through all this, through the lumpectomy. Perhaps maybe in the years to come, we will be looking at, smaller excision or limited excision, and then, because being a very important organ, and with the genomic thing coming up, perhaps, that could be the thing. Well, as it stands today, the common iliac and bifurcation would be the correct approach at this point of time. Maybe you can have some other discussion. Maybe Raj Pruthi, if he had been there, he would be ready to answer something else.
Only thing which I'll say, that in Indian patient, which Mallika Arjun said, if the patient has a history of filariasis, then the yield of the nodes may be high, and which is logical. These patients do have a lot of lymphadenopathy, and there's a lot of chyluria also. But I have not seen these patients, particularly I have not taken the history. At least in Delhi, we don't see much filarial patient, but sometimes we do see the patient who have, even after radical prostatectomy, patient had, so much chyle leak that we had to ask our radiologist to put a dye and then help us in doing that, because the patient came in post-op with ascites. So Mallika Arjun does have a point, and probably we can look into this aspect also when we do the lymphadenectomy of these patients. As far as the technique of high volume center is concerned, I feel the same as it is done anywhere else in the America or West Europe. People are doing good lymphadenectomy. I have seen many videos and young guys operating, so that's not a problem at all.
But one thing, I think Sudhir, we need to, in South India, we do see a significant number of patients with previous lymphadenitis and filariasis, which we see quite often. And even in donor nephrectomies, we see a large packet of lymph nodes coming up in the retroperitoneum. In one of those patients, I had a 4-liter lymphatic leak coming up. We are writing that after a radical prostatectomy, which I had to go back again and suture. And even now it is not settled. He still has got a lot of ascites requiring tap once in 15 days. So the brain history, I just want to have a discussion, because the history now goes on. I'll take a history of whether he had filariasis or not before. Patients with chyluria, or typical, especially patients with chyluria, you had history of patients of chyluria, I would not do a lymph node dissection at all. If there is a history of chyluria, let us not touch lymph nodes. I think
you do have a point, Mallika. In Delhi, we see once in a while. Like I told you, one patient I have seen so far. But you do have a point in South. Maybe Santosh, do you have this thing in Vellore?
I think Dr. Santosh will also like to give his comments on the
Yeah, after all the giants have spoken, please. You have requested me to speak. My first comment on Dr. Ashwin's thing, ERAS, I think it's more of a teamwork rather than a surgeon or an individual. And he quite pointed out all the points very clearly. See, there are 22 or 23, whatever you want to take it. Some say 23, some say 22. You are not comfortable with everything as a team. And as seniors, I think we are the ones who are the biggest culprit. All our life, we have been doing something which is not to the mark. And I think we have to, the GI surgeons have taken the lead, and we need to follow them. They took it up before us. Their patients with malignancy have a worse nutritional profile than ours, and they are doing bowel and osmosis on these regularly. So we need to take the lead from them, and whatever we are comfortable with, 10 points, 9 points, we as a team sit together with anesthetists, junior doctors, nurses, and the senior consultants, decide that this is what we'll do. And I very well pointed out that we need to go back and then add on more points or see where we are going wrong. It is very bad to think that in India it's not possible of this thing. All I think oncologists are doing it. The ones who are not on board should just get on board. The ones on board should try to implement more and more things as required. I think that was for Dr. Ashwin, and Dr. Gagan, I think, summarized things very well. I think as far as lymphadenectomy is concerned, very clearly one size does not fit all. So you cannot say that I am doing extended, I'll do standard, or I'll do super extended. So it's not possible to say that I will do all. So that is one thing. Second thing is, we should know very clearly from the lymph node studies, sampling which have been done, that the standard lymphadenectomy is probably okay for T1, T2, N0 disease clinically. The ones which have a higher chance of nodes are the ones which have a higher chance of node at the common iliac and the para-aortic level. So I think very well, Dr. Gagan, you have pointed out the problems with the RCT, but I will tell a little more. what was the inclusion criteria of the RCT. They went and took on patients who were N1 and N2. Now, if you look at Dr. Kulkarni mentioned Dr. Skinner's series and other series. In 1995, approximately, all these results came out, and there were approximately 200 patients in all these series. And they all proved beyond doubt there were patients with N1 disease who lived, 30% of them lived without any neoadjuvant chemotherapy, without anything, and they had a very long-term survival. So it is very well proved in the past that patients with lymphadenectomy without any other therapy will live. So who are these patients? These are patients who have only N1 disease. So these are patients with very limited node disease, very low down in the pelvis. These are the only ones who will benefit. For the rest of them, it will not. Now, as far as lymph nodes, I think Dr. Mallikarjun took out about the number of nodes. I don't think number of nodes is different in India and any other country. I think filariasis is more of a problem in the renal hilum than in the pelvis. The pelvis, so many lymphadenectomies we have done, we don't see that much problem in the pelvis. Now, what is the problem in the pelvis? We have looked at our retrospective data and we have found when patients with nodes have had neoadjuvant chemotherapy. Classically, if you see the neoadjuvant trials, all the neoadjuvant trials have N0 disease. The ones which have shown benefit, you look at carefully at the inclusion criteria, all of them are N0 disease. Now we start giving neoadjuvant in patients with N1 and N2 disease. So actually, if you give neoadjuvant in N1 and N2 disease, you need to give curative therapy, not 3-4 cycles. You need to probably give 6 cycles in them. And what happens in them is that those nodes are encasing the vessels and they just infiltrate the vessels. And doing lymphadenectomy there becomes very difficult. So we have realized that the lymph node yield is less in patients who have had neoadjuvant chemotherapy and clinically positive nodes. So those are my only comments.
Hello.
Shall we?
I am there, sir.
Vivek, if you want to summarize and then move on to the next.
Sure, sir. I think we can move on because I think Dr. Pruthi is not yet logged in. Yeah. I see only a couple of questions on the chat box. One for Gagan. The number of lymph nodes, is it unilateral or bilateral? That was one of the questions in the chat box. If you just want to quickly give that answer.
Yeah, both sides.
Yeah, of course, both sides. And the one for ERAS, but I can't really understand what that question is. LIEUS. Yeah, so let's just go ahead.
Just 1 second. The one point to add, I think somebody talked about a prospective trial. The Bhubaneswar AIMS has already registered our prospective trials in the indiantrial.gov.in. And they have already included a lot of centers. I don't know whether you feel that you don't want to be a part of it, then you can run a parallel trial. They have target, I think numbers were 450, and they're planning to do extended versus standard. And they wanted to include everyone with T1, and they also wanted to stratify according to institutions and neoadjuvant. So I request anybody who wants to join that should be happy to join. If you want to say that we don't want to be a part of that group, we want to do a parallel, maybe 400, 500 patients, and amongst your group, you think that you have that many patients and you can follow them for 5 years. So there is already a trial which is already on the IRB of the institutions, and this is going to go through the clinical trial. So either you join that or create another one on the same thing, but you need around 500 patients. So you have to make sure that you get that many patients with that many numbers.
Thank you very much, Prajing, everybody.
Thank you. Rakesh, do you want to take over?
Yeah, Sanjay. So we move on to the session 3 as Dr. Rajputi has not logged in. So the next session, I'll invite the moderators, Dr. Indranil Banerjee and Dr. Saurabh Patil will be the moderator for the next session. You can invite your speakers for the next session.
Good evening, everyone. We have the debate of the evening lined up first. Dr. Santosh Vaigankar will be speaking on radical cystectomy in muscle-invasive bladder cancer. He is a consultant urologist from Cochlear in Mumbai. Over to you, Dr. Santosh.
Okay, can you hear and see me, please?
Yeah, we can hear you and see you.
Okay. Sharing my slides. I always prefer to start the innings after winning the toss, especially knowing that the opposite team can't chase. Going into my presentation. Okay, is it visible?
Yes.
Thank you. I'll be talking about radical cystectomy as a part of a modality of treatment for muscle-invasive bladder cancer. A quick overview, as we know that bladder cancer, and if you look at the Globocan data that it has a formidable presence. And if we move on to my topic of choice would be radical cystectomy. Now, radical cystectomy, as we know, has stood the test of time, and over many decades, it is still a formidable treatment modality for muscle-invasive bladder cancer. But the most important immediate effect of doing radical cystectomy is a psychological relief to the patient that he no longer harbors the tumor-bearing organ in his body. Not only that, we are also able to give him options of choosing the approach in which he wants to undergo the surgery, either open laparoscopic or robotic approach. And we also have options of either an ileal conduit or a neobladder as a urinary diversion for him. In fact, going ahead, we can also offer nerve sparing approaches in young individuals and also organ sparing approach in young females who would like to retain their fertility. Of course, these are carefully selected patients, but I'm not too sure if this would be possible if trimodal therapy is planned. In fact, if you go for evidence, there are plenty of them. I would choose a few to show you. One of the Cochrane review data of 5 published randomized control trial showed that the time to recurrence, positive surgical margin rates, grade 3 to 5 complications, and quality of life were comparable in robotic and open radical cystectomy, whilst transfusion rate was less in robotic assisted radical cystectomy. Now we have all this is a multi-institutional database of 800 patients who underwent radical cystectomy for bladder cancer, and the 5-year recurrence-free survival was around 58%, and the cancer survival was around 66%. Talking about ERAS, I think Ashwin has already mentioned that this is a new concept which has come into for providing good outcomes to the patient who undergo radical cystectomy. I'm not too sure if any such protocol exists as far as radiotherapy is concerned. Moving on to the RAZOR trial, one of the authors are there with us today. It went on to tell that robotic cystectomy is non-inferior to open radical cystectomy, except as far as blood transfusion is concerned, which is very less in robotics. So all I want to emphasize that we've got options, we have got randomized controlled trials to prove that radical cystectomy can be offered to patients with muscle-invasive bladder cancer. Well, this is an important point, that histological variants. In fact, the EAU has acknowledged that the only treatment available for a histological variant is radical cystectomy and lymphadenectomy. Moving on to talk about TMT, we have only few evidence which aren't strong enough. Talking about the first is a paper by Rick et al., who identified around 6,000 radical cystectomies and compared with 700 all TMT patients. And he found that the worst survival was linked to higher age, comorbidity, and tumor stage. After modeling the whole data, TMT resulted in lower mortality at 1 year. However, in years 2 and onwards, there was a significant and persistent higher mortality after TMT. That's the graph. The second paper analysis was based on more of a larger cohort, and with 22,000 odd patients undergoing radical cystectomy and around similar patients undergoing MMT, it was found that survival after modeling was significantly better for radical cystectomy. That's the graph, the Kaplan is showing the same. Well, talking about systematic reviews, this is one review by Omar Fani, which he looked at 57 studies and studied over 30,000 odd patients, comparing radical cystectomy and TMT, and found improved 10-year overall survival for TMT. But for the entire cohort, the overall survival and the disease-specific survival did not significantly differ between both. Most important feature when you talk about therapy, especially in a part of I tried to look at radical randomized controlled trials, but I couldn't find any. So moving ahead to a most important aspect of treatment is cost, especially since we are in a developing country. In older patients, potentially who are less ideal patients for radical cystectomy, Williams found a significantly lower overall survival for TMT as compared to surgery, as well as increased cost. The difference in costs were largely attributed to medication and radiology expenses associated with trimodal therapy. Now, extrapolating these cost figures resulted in a nationwide excess of around 500 million for trimodal therapy itself compared to radical cystectomy. I can't imagine the cost burden that would be unveiled if the same study were to be carried out in a developing country like India. Now, Dr. Srinivas would agree with me if I say that even after trimodality therapy, the bladder still remains a potential source of recurrence. Hence, long-term bladder monitoring is essential, and patients should be counseled that this will be required, that is the salvage cystectomy. In fact, a sub-analysis of 2 RTOG trials looked at response after MMT showed that after a median follow-up of 5.9 years, patient experienced bladder recurrence and few required salvage cystectomy. In fact, the paper which I put up right now, it's a last series from a high-volume center, and it demonstrates no difference in perioperative mortality in primary and post-radiation salvage radical cystectomy. Similarly, there was no significant difference in the incidence of most of the surgical and medical complications in either of the groups. So my question to Dr. Srinivas is, why should the person undergo that trimodal therapy if he's going to land up into cystectomy later on with the outcomes which are similar to primary radical cystectomy offered to the patient upfront when he's diagnosed with muscle-invasive bladder cancer? Now we'll go to a topic which is very simple discussion. Yes, I'll be finishing. The Indian scenario has got challenges. The present study showed comparable surgical and early perioperative outcomes as far as the surgery is concerned. Now this is a TMT protocol. It has got TRBT, chemo, radiotherapy, followed by cystoscopy, possible recurrence leading to salvage radical cystectomy. Now, will this all be possible in our part of the world when the 2 most important factors affecting treatment in India is cost and compliance? And I've already discussed about, spoken about cost earlier. So to end, my take-home message for everyone and my colleague is that TMT is in population-based studies inferior to radical cystectomy. In India, not many patients may be appropriate to have TMT. It is not cost-effective, and patients' compliance is a concern. I rest my case. Thank you.
Thank you, Dr. Santosh, for finishing on time. I will invite now Dr. Srinivas Chilipuri, the consultant radiation oncologist from Proton Apollo, Chennai, to counter Dr. Santosh's arguments.
I'm just stopping sharing, just a minute.
Sure. Yeah. Over to you, Dr. Srinivas.
Good evening, everyone. Thank you, Dr. Santosh, for a nice talk. And I will put forward a case for trimodality treatment. And I agree with Dr. Santosh that organ preservation as a treatment strategy is not for everyone. And it is a time-tested strategy in oncology, not just for bladder cancers, but laryngeal, anal canal, lower rectal, breast, and limb preservation sarcomas. It's been there for a while, and it's nothing new as far as oncology is concerned as an organ preservation as a treatment strategy. The main criteria for organ preservation is to see whether there is no compromise in survival. If there is no compromise in survival, if there is a high likelihood of eradicating tumor, the low risk of local recurrence, and no compromise in organ function. So if these 4 criteria are met, one could consider organ preservation as a treatment strategy. Probably the 5th one, which I missed here, is if you are able to safely salvage local recurrence, that could be definitely one of the criteria for organ preservation. And it has been successfully used. And as I completely agree with Dr. Santosh's, at least partially, that it is not for everyone, and for organ preservation to be successful in any cancer, patient selection is extremely paramount. And of course, there are many other factors which needs to be considered. So you have a muscle invasive bladder cancer, you go through a multidisciplinary clinic, you have several prognostic and predictive clinico-pathological factors. You want to do a bladder preservation strategy or not. I think the trimodality therapy not just includes maximal TURBT and chemotherapy and radiation. I think it is a 4 modalities, which, as Dr. Santosh mentioned, active surveillance is an important component of this approach, because we need to detect an early recurrence. It could be a non-muscle invasive, it could be a muscle invasive, that needs to be detected and dealt with immediately. Well, there is a slight controversy regarding RTOG, which is an American approach, and Erlangen, which is more of a European approach. That in European oncologists have always been practicing completing chemoradiation and then going for assessment of response, compared to American colleagues who have done kind of an induction radiation therapy where they give about 45 to 50 gray, and then they assess the response. That is kind of an interim response rather than a response after completion of treatment. And there is some literature that if the patients who undergo cystectomy, when they have a local relapse after a CR versus those who are not responding to the initial chemoradiation, if you the patients who are having a poor response or a non-CR to initial induction chemoradiation anyway do not do well. So it doesn't matter whether you stop the treatment in between and assess a response, or you let them complete the treatment and then you take them up for assessment of response. In fact, you are giving them more time for response, and non-responders anyway don't do either ways. So typical, what are the long-term outcomes? Long-term outcomes, about 70 to 75% of them achieve complete response rate. Just for your information, neoadjuvant chemotherapy, the typical PCR rates between 25 to 30%. With addition of immunotherapy, it's about 40 to 45%. Nothing beats chemo-RT. The CR rate is close to 3/4. And as you see that those patients who do not have complete response, there are some who still have a superficial residual, which is non-muscle invasive, who could still undergo non-invasive treatments, and those who, of course, have muscle invasive recurrences undergo cystectomy. And at least the RTOG studies have shown that 80% of those who are alive at 5 years still have their native bladder preserved. So essentially, it brings us to three questions, which I would like to answer in the next 4 or 5 minutes. Who is the ideal candidate, and what are the perceived barriers to bladder preservation and how to address them, and what is the future for bladder preservation approach? Who is the ideal candidate? We've always heard that the patients who, in most of the trials, most of the prospective, retrospective studies have included only the urothelial malignancies, the TCCs, tumors allowing a visible, complete TURBT. Typically, a T2 patient is the one who is an ideal for this, or a T3A who's less than 6 centimeters, no tumor-associated hydronephrosis, no extensive CIS, adequate renal function, and a good bladder function. It should be a bladder worth sparing. So let us address a few other aspects apart from these, which we all know that who is an ideal candidate. But what happens if it is a variant of unknown, variant urothelial carcinoma? This is a very good study published from Mass General, which has been the capital, one of the main hubs for trimodality therapy. They saw a large chunk of variant urothelial cancers, including squamous, glandular differentiation, sarcomatoid, micropapillary, and they found that the result did not actually change much. Of course, there are no prospective long-term studies for these patients, but at least some indication that some of these patients could do as much as the typical TCC histology. How big is a deal is a complete TURBT? This is data from BC 2001. Almost 1/3 or more than 1/3 of them underwent only a biopsy, not a complete TURBT. And those who did not have a complete TURBT had a same low co-regional disease-free survival compared to those who did. And there are many other now multi-institutional studies which have actually have irradiated patients who do not have complete TURBT. Of course, an ideal patient is always a patient with complete TURBT, but probably there could be a case for patients who do not have a complete TURBT could also be considered for trimodality therapy approach.
Last 1 minute.
Sorry?
Last 1 minute. Sorry about that.
T3A would be the most patients. But what are the perceived barriers? Main barrier is the clinical outcomes. Most of the prospective studies have shown that they are comparable. Whatever other studies are there, they are all biased, and you could know they are different set of patients. Older patients who are not fit for treatment, multiple comorbidities, unresectable disease, basically increasing the self-fulfilling prophecy, resulting in inferior outcomes in patients. So comparable outcomes between two modalities. Salvage cystectomy is as safe as as a primary cystectomy, as shown in this series from MSKCC and Mass General hospitals. The toxicity is quite acceptable. The quality of life is actually, there have been some comparison between radical cystectomy. There are certain advantages to chemo-RT compared to surgery in many prospective studies. And in the future of bladder preservation is probably knowing the molecular molecular understanding, molecular milieu of bladder cancer, and probably tailoring bladder preservation approaches to a particular set of patients is probably going to be the future. Thank you.
Thank you, Dr. Srinivas, for the excellent presentation. I will be back to Dr. Santosh again for the review. To you, Dr. Santosh.
Thank you so much. And Srinivas, well done. I really appreciate your effort. But there is still no doubt in my mind that, and I'm sure majority of the faculty here, I'm just sharing my slide, I'm sorry. Majority of the faculty here.
Can you please...
Okay. Yeah, can you see my slide? I'm sorry for this.
Yes, we can see that.
It's a very good effort, Dr. Srinivas, but there is no doubt, and I'm sure majority of the faculty here agrees that radical cystectomy is clear winner. I've not seen any RCTs been put up, but before I close, I'd like to play my final card. It's a very strong evidence, and this paper mentions that India must grapple with over 1.5 million new cancer cases every year. And over 60% of these patients will require radiation therapy, and the country is under-equipped currently and in the foreseeable future. Now, there are several challenges in delivery of quality radiation therapy in India, which include lack of adequate infrastructure and availability of adequate radiation professionals. So I believe we need to get our priorities right, and TMT might appear as a good option, but it isn't. I rest my case. Thank you.
To address those things, first of all, randomized control trial isn't there, but that is not there even for in the favor of surgery. As I mentioned, at least the indirect comparisons have shown that surgery and radiation or trimodality therapy results in equivalent outcomes. Most of the studies which have published are for different set of populations. TMT is for older population, TMT is for comorbid patients with a lot of comorbidities, TMT is for inoperable patients. So these are different set of population, and anybody who can put their hands on the heart would know that there is no good quality evidence to say that radical cystectomy is a better option compared to trimodality therapy, plus, of course, a salvage cystectomy if required in the future. The second thing which is he mentioned about the cost. Cost is a concern. Active surveillance is an important aspect of the trimodality therapy. Nevertheless, in a social medicine, of course, maybe surgery would be important, but for a patient who can preserve the bladder, who can preserve the function of the bladder, I mean, there is no argument that whether it's oncologists or urologists, the patient's preference would be an overwhelming favorite with trimodality therapy because they're able to preserve their native bladders, at least for some time. Even if they undergo salvage cystectomy, they are able to preserve their bladders. And in India, where radiation oncology facilities are scarce, that's what, I mean, we all know that radical cystectomy in good hands, in high volume centers, lead to better outcomes compared to those low volume centers. And of course, high volume centers are limited. So that argument goes for almost every other modality. So that is what I want to say.
I'd like to thank both the speakers. There is a question for Dr. Santosh from Amandeep Arora. What do you tell your patient with a CT2 disease? Why he should not consider CTRT? You are muted. Dr. Santosh, you are muted.
Yeah, that's a very good question, Amandeep. And probably you will also face the same question when you get in practice. But I'm not saying that I don't give the option to the patient. Obviously, the patient, once he consults me, he's always directed to the radiation oncologist who also discusses the pros and cons of radiation. I'm not in any position to tell them radiation is good or bad because I leave it to the professionals. As far as radical cystectomy is concerned, I'm very well equipped to tell them about the pros and cons. But as the radiation is concerned, I always respect the advice given by my radiation colleagues, and I always refer the patient to them. So I'm not the one who talks to them about radiation. Let me be very clear. I hope I answer your question, Amandeep. Can you follow the same?
Thank you for the excellent answer, Dr. Santosh. So there are no more questions in the chat box. So we will move to the next talk, and I will invite Dr. Sudhir Rawal, who needs no introduction, to talk on the ideal urinary diversion. Over to you, Dr. Rahul, sir.
Thank you, Indranil. Can you see my slides?
Yes, we can see.
It was the talk which was supposed to be given by Dr. Hassan, and I don't know why he is not responded. I hope he's all right in this COVID time, because he agreed to participate, but suddenly there is no response from his side. Some maybe problem there. So then Rakesh asked me to speak on that. Is there any ideal urinary diversion, and how do I select? Okay, so I have no conflict of interest. One thing I'll say that the options for urinary diversions are good old time tested ileal conduit, but may not be acceptable to every patient. Many times patient actually delay the surgery, or he does not want a conduit on his abdomen, a stoma on his abdomen. The second is continent catheterizable pouch. Did not become very popular because there was a very high complication rate. Almost 70% of the patient they returned in first 2 years. That is why it was given up. It started with a very good response, but then it was given up because patient had complications, and then the orthotopic neobladder. This in chronology also. Orthotopic neobladder came, and the acceptance is better, and still the patient, many patients, they come for having the neobladder only because they do not have any stoma. But the problem is that it cannot be offered to all patients. And we can do cutaneous ureterostomy also. We should not forget this type of diversion in very highly selected patients who are very morbid or who have another problem like renal failure and all. So this is the old slide. Here it is saying till 2004, and you can see that the ileal neobladder, orthotopic neobladder was going up, and then continent catheterizable pouch, they came, and they 1983, 86, they were on peak, and then they came down. As far as conduit concerned, they were quite okay, and then they came down. But this thing after 2004, I'll say the conduit is picking up and the neobladder is coming down. All we know that orthotopic neobladder, we have advantage of there is no stoma or associated stomal complication, especially parastomal hernia, which is very common. There's a left effect on the physical image and comparable or better postoperative sexual function if the patient has had orthotopic neobladder. And but then there are some changing data in the ileal conduit. As I told you, that ileal conduit is now picking up because of there are some inherent problem with the neobladder. These are again the incidence of neobladder is offered in the different center, like Bern offers around 54%, and then we'll talk about Ulm, it is 66%, while in Mansoura, Egypt, it is only up to 40%. We were offering almost 60 to 70% one point of time. Now we have started choosing our patient because the many times these patients may not do well if you offer them this type of surgery above 70 years. Though I have one patient who actually wanted neobladder at 78, and recently I saw him is 88, and he is still should not be compared. We all know that what is the underlying pathophysiology in bowel interposition into the urinary tract, and this I will not go in detail. Only I will say that these are the main segment which they absorbs, like carbohydrate is absorbed throughout GIT, then protein also, the lipids, and this actually will guide us the complication in long term of these segments when you use either ileal conduit or neobladder. These are the segment which can be used for conduit or for the neobladder, rather than stomach is mainly used for augmentation of the bladder when it is patient has renal failure. We used to do gastrocystoplasty, but one can do it also from the stomach. Jejunal conduit should not be used because it's a net secretory epithelium and the patient can have very bad electrolyte imbalance. They should be avoided. Then the ileum is probably ideal, but then these are the problem with the ileum: hypochloremic, hypokalemic acid metabolic acidosis, and same is with the colon. Then segment, if you see the different type of GI segment, ileum, ileocecum, colon, jejunum, and stomach. Only thing which I would like to say that there were many people were doing sigmoid neobladder. Problem with sigmoid neobladder is there is a high pressure, and that is why they were incontinent. So those who are doing, they also have given up. I have used ileocecum personally in the beginning of my career, but I had to give up because many times there was a problem in reaching the segment to the urethra, and also ileo-ascending anastomosis will leak, which was not very friendly, especially in post-op. So we switched over to ileal neobladder later on. This is one can say in summary what are the complication can occur when you use ileum for the urinary diversion. One is altered bowel function because you have taken some part of the terminal ileum, malabsorption, acid base balance, electrolyte abnormalities, bone demineralization. There may be calculi formation. Only thing which I'd like to say, these calculi, they are very soft calculi. You can even wash them. There is no need to do lithotripsy or anything. You can catch them and remove. So this thing one should remember when you are dealing such cases. Their renal and hepatic function can be deranged, and there is impaired drug metabolism. And this point actually has to be kept when you are using post-op chemotherapy, adjuvant chemotherapy, either MVAC or DDMVAC or maybe anything, because in that segment, especially in the neobladder, it has to be catheterized rather than you ask the patient to keep widening in ileal conduit. This may not be a problem. Does the longer segment in neobladder affects any acid-base disorder? This is the paper which address this, and it says there is no significant acid-base disorder when you use ileal conduit or the neobladder, provided the EGFR is good. You have to see the EGFR rather than blaming the segment or blaming the diversion. So, do we require chronic alkali therapy? This has been addressed by Hassan group only in a prospective study where they used 100 patients. They gave consecutive, were maintained on regular alkali therapy since surgery, and in 100% they stopped after 3 months. And there was actually control patients also. They kept control on 40 healthy male also. And in them they showed that clinically irrelevant ionic concentration difference in the pH is same. So there was no problem if you stop alkali therapy after 3 months, but in practice we continue. Especially in the diabetic patients or they have renal failure, minor renal failure, it is better to continue. You have to have good renal function if you want to stop this thing. And they concluded also in this paper that patient with non-complicated ileal neobladder with normal upper tract, you have to see the normal upper tract, otherwise, because sometimes there is a compromise in the upper tract, and who are not maintained on alkali prophylaxis for a long period have compensated acid-base status. Therefore, the prolonged alkali prophylaxis is not mandatory. So, if suppose metabolic thing is not there, what we choose about neobladder and conduit? Does the anti-reflux technique, they make difference, or refluxing and anti-refluxive? And these are the papers which have addressed this issue from the Studer group and Skinner group. And they have showed that whatever you do, anti-reflux is T-pouch or refluxing is Studer pouch, though that also claims some anti-reflux mechanism, but it is in particular, it is not. In reality, it is not. But then there is hardly any difference, but there are some data that anti-reflux technique can lead to deterioration in the renal function in long term. But the main thing which will be important is ureteroenteric anastomosis strictures. If there is a stricture, definitely the renal function will suffer, and that's the main concern when you do any type of anastomosis from the ureter to ileum. And that is why you have to do very simple ureter to ileal anastomosis rather than going for a complicated. Now, there is no technique which is superior. So what are the contraindications when we choose the diversion? we have to see for neobladder. If the patient is motivated for neobladder, you have to see the patient is not having liver failure. Patient with preoperative creatinine clearance of less than 60 ml will not be fit for the neobladder. If they have some kind of liver failure, then also they should not be offered neobladder. Also, the patient who have Crohn's disease, irritable bowel syndrome, some malabsorption syndrome, or ulcerative colitis, you should not offer neobladder in these patients. Now, this the one indication, the high dose radiotherapy to abdomen, yes, probably you may avoid, especially if the terminal ileum has got. But in the pelvis, like in salvage cystectomy after radiation trimodality treatment, you still can offer neobladder because the technique of radiotherapy have improved like anything. I remember in 1996 when we started doing this surgery, when the hospital came, there are a lot of patients, they will come very badly irradiated terminal ileum, and if you use that, then definitely patient is going to have leak, fistula, everything. So in those patients, we used to do transverse colon conduit. But lately, when the radiotherapy technique improved, then we could do neobladder to these patients. It's not that you can't do neobladder, but this is optional. Elderly patient more than 70 years, you should avoid because these patients do have a sphincter weakness and they will be incontinent more in the night and maybe in the day also, and also patient with a spinal cord injury. The extensive disease at bladder neck involving prostatic urethrectomy should be done. Metastatic disease, one should not offer this type of diversion. And the stricture urethra also is a optional, patient will end up with CIC because they are the low pressure bladder and these patients will not be able to void. And in most of cases, however, the choice will not be driven by the obvious physiological or disease related factor. The deciding factor will be patient's choice, because if a patient who wants ileal conduit, you better give him ileal conduit, don't give him neobladder. But if the patient is very highly motivated, don't give him a stoma. He will curse you his whole of the life and he may come back to you for undivergent to do the neobladder. And this has been shown in this paper nicely. They have taken few factors. What happens is, according to that paper, this is that if the patient was normal body image, he wants neobladder. Normal sex life, better sex life in neobladder. Less complicated operation, patient himself can actually agree for ileal conduit, and also fear of incontinence as can be with the neobladder. He might have seen his friends or some family member who has had neobladder having nocturnal incontinence, so he himself will make a choice. Other thing is that many patients have fear of voiding. When the bladder has very irritative voiding symptom, these patients they will be very happy with the ileal conduit because they don't want to void. With the dysuria, urgency, frequency, urgent incontinence, they better feel that we should have ileal conduit. So it's the patient's choice rather than you should not offer straight away that I'll do neobladder on him. Discuss with the patient everything and then decide. So other thing is that the functional outcome about the potency, I have already told you, the better with the neobladder, and it can be it can be with the ileal conduit, but with the stoma, patient generally avoids having sex, but you have to save the nerves for this, either preferably on the both side, and these are the data which have shown that nerve sparing patient, there's a good amount of the patient can preserve their sexual function and the nerves. When you are going to save, there is a practical point. Don't do very extensive lymph node dissection at the bifurcation of aorta because there are the nerves which goes in the sigmoid mesentery, and these are the nerves, if you cut them during the extensive lymph node dissection, then you can save the nerves ahead at the side of the prostate and the bladder, but the patient will be impotent. So you have to start saving the nerves from the root of sigmoid and go down at the base of the seminal vesicle and then go to the lateral pedicle of the bladder and prostate, and as you do in the prostate later on. So this is doable very nicely, and the results are quite okay if the patient is going to have the neobladder. And also there are some data when you save the nerves and you offer them neobladder, then the continence is better, as it happens with the after the radical prostatectomy. This is the study from India, from KGMU Lucknow, and they actually compared the neobladder and ileal conduit quality of life in a statistical model. And these are their results. I'll just summarize their results. is that they showed that neurobladder is better in physical functioning and social functioning, and it is also cheaper in long term because there is a very big expenses of the bags, conduit bags, which all are they are no Indian bags, and the bag which are available, they come from abroad, and they're not very cheap. Modification of neobladder to optimize outcome is you can see that a Studer and a picture spot which we published, and they have this double folding which we do, then W and M configuration with Hotman and abolonine. They do vertical folding, and there is a spherical folding is vesica ileal Padua pouch. What has been many times criticized, but everybody has used, is the neo-urethral tube, which we are doing since 2005. I think 2004 or 2005, yeah, 2005. And we have done more than 800 bladders. We have recently sent the data to EAU, that paper I'll be showing. Everybody uses this, some modification, so that the urethra will reach to the neobladder easily. And but many people do not accept that. They say this will get kinked. Happens is when you use at least 2.5 centimeter of the tube. It never happens, as we have seen in last almost 15 years. Now the mechanics and biophysics of the neobladder. Just I'll read out this as a good thing which I got. So I thought I'll share this. Urodynamic goal of any bladder substitute should be to replicate normal voiding behavior. It may not happen, but it should be like this. Maybe in future when we have the genetically engineered bladder, then that time probably it may happen. Neobladder should hold at least 500 cc of urine at low pressure, less than 15 centimeter. One thing is that one should not do the urodynamics of these neobladder because they don't have diffuser. So there is no point in measuring the pressure in those. But you can do uroflow rate and ultrasound residual urine. They should be able to empty completely, at least less than 100 cc, 4 to 5 times daily. Allow the patient to sleep without awakening while maintaining a large normal body image. And this is one thing which is only case achievable on 60% of the patient. 40%, they have to get up to pass urine or they wet themselves. So you have to tell them to drink less after 8 p.m. Don't drink anything after 8 p.m. and empty your bladder at 11 and put an alarm at 2 a.m. The success of orthotopic neobladder to store urine relies on detubulization of the intestine segment, sufficient capacity, proper configuration, positioning in the pelvis is very important in female. Otherwise, most of these female, they will end up with the hypercontinent and they'll end up with the CIC. And the ease of reaching of neobladder to the urethra so that healing is without fibrosis. And if there is any fibrosis during the healing, the patient will end up with the CIC. And we all know that Laplace law says that the spherical configuration is the best. These are the different segment length which are used in different neobladder. I will not go in detail. This is thing which we do. This was published in original paper in 2006, where we were doing with the open technique, and the detailed technique is there already in the on the Google, even in the YouTube also. This gives you another extra length of the 2.5 centimeter, so that the bladder reaches to the urethra easily. This is the paper which was accepted in EAU recently, and we actually had virtual meeting. So we send our video for this thing, and this is how the bladder is made. You detubulize, and at 20 centimeter proximal to the distal end, you go towards the mesentery about 5 centimeter. You stay there and come back to the anti-mesenteric border. Then you again detubulize at 20 centimeter. Posterior plate is sutured, and then this flap is sutured vertically. Only 2.5 to 3 centimeter suture, they go vertically. After that, there is double folding. It's a completely spherical shape which comes in picture spot ileal neobladder. And in this paper, we provided the data for more than a decade following aim to determine the quality of life in these patients. This was prospective and maintained surgical registry of all consecutive patients having undergone picture spot ileal neobladder since 2007 and 2017 who were alive and who they were actually asked the questions. Quality of life was assessed on each following visit of the bladder cancer index, which is the disease-specific instrument assessing quality of life across the bowel, sexual, and urinary subdomains. And multi-level, time level 1, patient level 2, randomized, intercept randomized, random effect models for each subdomain quality of life score as dependent outcome were created and adjusted for confounders which included the surgery, type of surgery, robotic open, BMI, T and NA stage, nerve bundle sparing, age, relative preoperative bladder cancer quality of life, and subdomain score. This all the data, I think these were taken by in our department by young urologists, Dr. Jiten and Amitabh. Jiten is very good in stats, and we analyzed 238 patients. Median age was less than 60 years, and most had no comorbidity. These are the demographic data. And if you see that these are the results, that bladder capacity rose linearly over 2 years before reaching a plateau, such that all patients could achieve the bladder capacity of excess of 400 ml. Post-void residual urine was average below 50 ml, and serum creatinine showed gradual rise in initial 2 years, then it came down. There were some technical changes in the ureteroileal anastomosis which I developed, but my juniors, they don't like it. They say that there is more stricture occurred in that era, so we have stopped doing. That may also have contributed to this. If you see the functional outcome, the median time to achieve day and night time continence was 9 months, 9 and 12 months, and less than 2% of the patient did not achieve continence, and 130, that 55% of the patient did not achieve potency. These 4 patients, and there you see after radical prostatectomy, some patients do have inherent problem of not doing exercise or not feeling the command. So these patients can have these things can occur with this bladder or any new bladder or the radical prostatectomy. All but 1 patient voided spontaneously per urethra without needing self-catheterization. That's the one thing, and that is why we do not even talk to them about CIC. The patient asks us what will be his future of putting CIC. We say most probably you will not require, because in the beginning you are incontinent, later on you get the continence. Then we teach them the time voiding and other thing. But with this new bladder, we have seen high residual urine, where we have scoped them and seen that this tube can have some time, coaptation of the mucosa, which after resection the patient improves. Now another sexual domain across were affected the worst and did not recover the preoperative level in many patients. That expected, because many of these patients are not even sexually active. Urinary domain score recovered preoperatively levels by 15 months and for most patients. All 3 domain scores were found to be significantly associated with time and inversely associated with the age. If the age is high, they have suboptimal outcome. Otherwise, in young patient, the sexual function were recovered very nicely. In conclusion, I can say for neobladder, that though most data is retrospective and prospective case series, and cohort ileal neobladder has been a reliable form of urinary diversion in terms of outcome and quality of life. There are only few studies comparing various types of neobladder. More randomized trial and meta-analysis are required, though it may be difficult to do. Every center has its own preference, but the surgeon should be trained for various types of neobladder and various types of diversion. So, controversy about open and robotic, Dr. Kruti will tell. Only thing that there is ample of data for an oncological advocacy of robotic assisted radical cystectomy, both in randomized and non-randomized trial. No randomized studies show a large magnitude of advantage in favor of RARC in terms of complication. Meta-analysis of RCT showed improved results in RARC for blood loss, time to passing flatness, and time to return normal tide. These are the things, other bladder which have actually copied the same technique. If you see by robot in Kroniska, he goes towards the mesentery, and same there's a USC in the Southern California, they also go towards the mesentery so that the bladder reaches to the urethra easily. So these are my final 2 slides, and I'll just address the question which was asked from me: is there a ideal diversion? How do I select? So I'll say there is no ideal diversion. but a diseased bladder gives lot of trouble to the patient. And therefore, any other way of passing urine will be accepted by the patients, especially the cancerous bladder. They would like to have it removed, and they don't want to keep that bladder. So any type of diversion will be accepted to the patient. Ileal conduit is simple, safe to do, but for many patients may not be acceptable, and many of these patients will go to alternative treatment and only to come back to you with the advanced stage, which we see most of the time every day or 2-3 times in a month. Orthotopic neobladder does not mimic completely the original bladder. Thus, you have to tell that patient that it will work, but it will not be like original bladder. I say because I'm in North, I say that kaam aapka chal jayega, but don't expect the original bladder which God has given to you. But is more acceptable ONB and requires some preconditions. This cannot be offered to all the patients and should be done after proper counseling and highly motivated patient in high volume center. And you can discuss about CIC depending on your results, on your technique which you are following, because there is no point in keeping patient in dark. Cutaneous ureterostomy can be offered to the highly sick patient with many comorbidities, and especially also the patient who have renal failure. Other thing are that patient's choice, age of the patient, comorbidity, stage of the disease, and query radiotherapy. I'm not precluding the radiotherapy completely, should be taken in account before deciding the diversion. Because urologists dealing such patients should be well trained in doing ileal conduit, ONB, and continent catheterizable pouch. Sometimes patient is requiring the urethrectomy, you cannot offer ONB, and he doesn't want any stoma. It is better to offer continent catheterizable pouch to these patients. They may be once in a while. Pre and post-op trained support staff is mandatory for counseling the bladder wash and other thing. ERAS, early mobilization, nicotine patch in smoker, bowel movement enhancing agent should be used in these patients because early they eat, early they recover. And I always tell my juniors also that surgery part is 40%, pre and post-op care of these patients is 60%. Thank you.
Thank you, Dr. Rawal, for the exhaustive presentation. And the cherry on the cake was the Indian data, large Indian data from your institute. There are a few questions in the chat box. You have partly covered it. One question is from Dr. Satish Kumar Gopal. Is it possible to do ureterostomy and offer a single cutaneous ureterostomy in patients with renal failure?
Generally, it should not be done. We avoid ureterostomy in cancer because if one disease ureter, suppose there is some CIS changes in one ureter, the other ureter will also get those things. It's only when you have salvaged, when you have sacrificed a big segment of the ureter, maybe till middle third, and the patient is not fit for conduit. Rather, I'll prefer conduit in these patients. But if it's not fit for, then rarely. But I think those situations are very, very rare.
Thank you, Dr. Rawal. Another question for Dr. Narayan Bhushal is, what's your opinion about incontinent neobladder versus cutaneous diversion?
No, incontinent neobladder should not be there, especially daytime incontinence is not there. Nighttime incontinence is common. But in neobladder, daytime incontinence we do not see. And continent cutaneous diversion, he means cutaneous ureterostomy or catheterizable pouch?
That's not mentioned clearly. It says cutaneous diversion.
Yeah. Cutaneous diversion, there are two things. If he's talking about catheterizable pouch, they should be avoided. Dr. Raj is already here. Welcome, Dr. Raj. We were waiting for you. But if you're talking about cutaneous ureterostomy, it should be done in very highly selective patients because applying the bag on these patients is not very easy. They have actually leak like anything. So that should be avoided in the healthy patients. Only the patient if is sick and there's not much, he is not having very long-term survival, then you can offer. Otherwise, one should always prefer to have either conduit or bladder or catheterizable pouch.
Another question is from Dimple Kumar. He says that if the transplanted kidney, the right iliac fossa with a native kidney inside, what will be your choice of diversion?
Choice of diversion, if the patient is ready, I will go for conduit. But having said that, it's not that you can't offer neobladder to him.
Thank you. Dr. Rawal, for the excellent talk. So we will move to the next talk, and I will invite Dr. Kulkarni to invite our star speaker.
Yes.
Good morning. Good morning, Dr. Raj, and good evening to all. I've been given the pleasant task of introducing our star speaker, Raj Pruthi, who is currently chairman of urology at the University of California, San Francisco. Just to give him, if he's a huge biodata, but I'll just highlight only 4 points. He completed his residency from Stanford University and joined as a staff urologist at North Carolina Hospital in Chapel Hill. And then he continued there till Jan 2020, where now he's taken over as a chair of UCSF. And I would just quote what Peter Carroll, who then retired, and he took over, said very astutely that I and entire department of urology at UCSF welcome Dr. Pruthi because his leadership skills match well with UCSF's culture and aspiration. Ladies and gentlemen, here we have Dr. Raj Pruthi. He's going to talk to us on radical cystectomy, open versus robot, a decade's experience. Thank you very much and welcome, Dr. Raj.
Thank you very much. And I apologize for a little bit of a delay. And just to check to make sure I stay on schedule, how much time would you like for me to have, sir?
30 minutes.
30 minutes. Perfect.
It's okay, Rakesh?
Yeah, sir, 30 minutes is fine, sir.
Perfect. Thank you. And if everybody can see my screen.
Yes.
That's good. So what I wanted to do is review what is now 15 years of robotic radical cystectomy data, comparing it to open cystectomy data, and then also reviewing with some video the steps of performing a robotic radical cystectomy. So this is a quote from now almost 70 years ago from Campbell in one of the original textbooks of Campbell's Urology, the first edition about cystectomy and about the concerns of bleeding frightfully. We know that cystectomy, as we start to look prospectively at complication data, 90-day data, that the complication rate is significantly high, with a large number, almost 3/4 patients having a complication, 67% complication in hospital, large complications are post-discharge. Half of the complications happen between 30 and 90 days, and half within the first 30 days. Readmission rates, 27%. That could actually be as high as 40% readmission rate. And 1 in 10, 1 in 12 patients have a 90-day mortality. And I think it's important to know this rather than often we quote in-hospital mortality or first 30 days, but 90-day mortality, if you ask the family, that's what they're concerned with. I think this represents a challenge for cystectomy, but with this challenge, I think is the opportunity. I think we're seeing the ability to improve outcomes, the utilization of adjuvant, neoadjuvant chemotherapy, and the development of less toxic agents such as immunotherapy and checkpoint inhibitors, and improving perioperative outcomes, pathways. And I'm going to talk to you a little bit about the role of robotic cystectomy. So we've seen the benefits of minimally invasive surgery clearly in cholecystectomy and nephrectomy. And I think we can start to think of that in radical cystectomy as well. So radical cystectomy, in my opinion, has potential benefits of less pain, less blood loss, less fluid imbalances, less bowel manipulation. But also there are some concerns that we have to address. We have to maintain the oncologic integrity of this operation. It is a unforgiving, potentially lethal disease. We have to make sure that the OR times are not excessive, and this is more than just a surgical stunt. Look at complications, look at costs, and what is the learning curve. And I'm going to talk to you a little bit about what is the value of the surgery. And when we talk about value, Michael Porter 10 years ago described it as outcomes divided by cost. So if the cost is higher, but the outcomes are better to a higher proportion, that adds value. But if we add costs without improving the outcomes, that's obviously decreasing the value. So how do we evaluate surgical quality for bladder cancer? These are some of the factors, oncologic outcomes. I'm going to touch on all of these, morbidity and cost as well. And I'm going to try to look at these and see, is there an advantage for robotics, a disadvantage of robotics, or one where there seems to be no difference. So let's chat with first about oncologic outcomes. So this is a collaborative group evaluation looking at lymph node, some of the factors on oncologic proficiency, how many cases you should do a year. I want to point to, especially, I'm going to come back to this, at least 10 to 14 lymph nodes during the case. And one thing here, positive margin rate, less than 10%. So when you look at open cystectomy series, you see ranges 1 to 14%, robotics 0 to 14%. These are just, again, comparing case series, but when you, in meta-analyses that are done, there seems to be really no difference in positive soft tissue margin rates between robotic and open. How about lymph node yield? We performed a prospective randomized trial, actually, of only 41 patients, but this was early and showed in non-inferiority of lymph node yield was the outcome, and there was no significant difference in lymph node yield between open and robotic. A variety of other robotic series here. You can see lymph node yields that are rather thorough and certainly higher than the Dr. Herr's collaborative group report. And I won't say that it's higher in robotics, but I think it's fair to say that there's no difference in the lymph node yield. How about survival? Some series from about 10 years ago looking at survival here. And Dr. Castle's report, Dr. Dasgupta out of the UK, and our report on 100 patients. And then here's other studies comparing open and robotic, as you can see here in the table. And to kind of cut to the chase of it, here's some more survival data, open and robotic and large SEER Medicare data in the US, and cancer-specific mortality. No difference in recurrence-free, disease-specific survival and overall survival between the two. So what now we've looked at is the RAZOR trial. The RAZOR trial is a large NIH-sponsored trial in the US with multi-surgeon, well-powered, looking at data. And the RAZOR trial at 3 years of follow-up showed, so this is the highest levels of evidence, no difference in progression-free and overall survival in robotic versus open. So from an oncologic outcome, we don't see a difference. Morbidity, let's take a look at some of those perioperative outcomes. We'll take these one by one. Estimated blood loss in that trial that we performed that I mentioned, which was, again, a small institution, but first randomized trial. And we'll see these themes over and over: less blood loss, a little bit longer OR time in our hands. Bowel function was a little bit faster, although length of stay was not a difference because we use an ERAS protocol for open and robotic, which I think is important, and less morphine equivalence. Some other studies, again, looking at that NICS trial is the one I was mentioning to you, comparing complication rates, robotic versus open. So there is data that is out there. Here's a meta-analysis looking at blood loss and transfusion rates. This is blood loss here, less for robotics. You can see up the leader here, and transfusion rates significantly less. Again, EBL and robotics and transfusion less likely. So I think this is one where it's clearly and repeatedly shown to be an advantage of robotics. Time, you do see longer OR time by about, so I mentioned to you here on average about half a liter less blood loss. Here OR time in our series is less than an hour, but in meta-analysis it's about 74 minutes longer robotically. And that's a consistent finding, so in some sense a disadvantage. Perioperative pain, Dr. Guru showed less narcotic requirements, morphine equivalents in robotics. I think this is an advantage. Length of stay in the meta-analyses, 1.3 days less. 10 studies showed a mean difference with robotics to be 3.2 days less. In the randomized trials, though, including our trial, we did not see any difference in length of stay. So potentially a benefit of that, but I don't think it's a clear benefit. So maybe a slight advantage to robotics. And I want to talk a little bit about complications. This is a paper we did looking at the 100 consecutive patients, our first 100, 41 complications in 36 patients. Other studies looking at robotic was a independent predictor of lower complication with 90-day complication rates of 50%. Higher complications in older patients, those who receive more fluids and greater blood loss. Looking at meta-analyses of this, you can see there does seem to be ratio less for robotics and analysis of the randomized trial. So I think this is an advantage of robotics. Quality of life, we looked at a study where we looked at the FACT bladder and the SF12 in patients undergoing robotic and open. At a mean follow-up of 2 years, there's no difference in any of the domains except for improved for interest in sex favoring robotics and ability to have and maintain erections, both higher for robotics. Looking at some other studies showing the FACT VCI, quality of life, and FACT bladder, the first showed higher physical well-being at 6 months. Another study showing no difference in robotic and open. So I think there's no difference in long-term quality of life, potential benefit, and short-term sexual function with robotics. And last, I want to touch on costs. When we talk about costs, if there's fixed costs and the OR costs and the robotic investment, variable cost, and hospital cost. Using the randomized trial I mentioned before, because that was a good example of again randomized to one versus the other, no selection bias, and there's no significant difference in cost. A study by Dr. Castle's group and by Jim Hugh. Dr. Castle's group showed robotic to be direct OR cost to be higher, but total patient cost to be lower due to reduced length of stay. In Dr. Hughes' assessment, in national comparative study in the U.S., no difference in cost. So I think uncertain impact with that. I would say that this is no difference in the financial cost between the two. So comparing robotic versus open, I think there's several factors where they're comparable, some benefits, some negatives. So going back to our value, these are improved outcomes, less blood loss and transfusion, pain, length of stay, and complication. The cost, so to speak, in this is longer OR time, which has a financial cost and an opportunity cost. No difference in a variety of these oncologic outcomes, costs, and quality of life. So I do believe that robotic cystectomy does increase the value of patients. And I in my opinion, I do think it adds value to the care of patients undergoing radical cystectomy. I do want to kind of with a little bit of time here, talk about the procedure itself, and I'll move through this a little bit quickly. Preparation when you start, picking the right patient preparation is important. As was discussed in the talk before, perioperative care is critical, and we'll talk about the procedural steps. I think if you embark upon robotic cystectomy, it should not be your first robotic case. I believe overcoming robotic prostatectomy learning curve is good to do first. So you get very much familiar with the robotic pelvic anatomy. I would recommend starting with a male patient, because if you get familiar with robotic prostatectomy, then you can make the transition over to cystectomy. There's less room for error in prostatectomy, and you should expect longer case times. Again, pick the right patient, right? Lower volume stage, maybe a non-invasive disease or a less bulky patient. Tools and instruments. So in the robotic, in my right hand, I'll often put monopolar scissors. In the left hand, use a fenestrated bipolar. In the third arm, I'll use this right here, which is called a bowel grasper or grasping retractor. It has less of a closing pressure, so you can manipulate the bowel if needed. And then 2 needle drivers. Typically, I'll use a 0-degree lens, and the assistant instruments you see here. So suture, I'll use 3/0 silk ties, pre-tied 8 inches to the kind of Hemalock clips to the crotch of the Hemalock clips. I'll use a 3/0 Vicryl on an SH to tag the bowel. If it's a female patient, I'll use a Vicryl on a CT2 or a CT1 here for the back bleeding stitch for male prostatectomy. I like to use the laparoscopic endo-GIA stapler. Positioning, outpatient prep, no mechanical or antibiotic prep, steep Trendelenburg position. I like to limit intraoperative fluids to about 500 cc's per hour. Port placement is shown here. The camera, this is at least 22 to 24 centimeters above the pubis. And then almost at the level of the umbilicus will be 8 centimeters lateral will be the robotic ports. And then I used to use a 15 and a 5 and a 12, and I've actually gotten rid of that and moved only a 12 and a 15 here. This 12 is needed for the stapler. So this is kind of what that looks like. Surgical steps. I'm going to go over these in detail, but this is kind of the rundown of the surgical steps. And I'm happy to share this talk and the steps with anybody after. Isolation of the ureter. You don't want to grasp it and crush it and avoid thermal injury or excessive traction, which can devascularize the distal ureter. So here we're getting going. There's that grasping retractor there, and our ileocecal valve, the appendix is there. So there we're tagging the terminal ileum. And now we'll kind of expose. This is the left side here, and you can see the ureter kind of coming. And it comes, see this reflection right here in the bladder. It'll typically come at that level. And then the cord will go straight up, and the iliacs will go straight up as well. There you can again see the ureter. So I'll lift up on the peritoneum and lightly score, and it'll get some air underneath the peritoneum, and then there you can lift the ureters off the underlying iliac vessels, and we'll kind of come underneath with this, and then follow this distally, again, avoiding crush injury, and I'll do a lot of peeling. If I'm going to use something, burn, it'll be plenty away. Often on the bottom end is where the vasculature is. I'm going to move along here a little bit. Here you can see. So now we're going to come in. I'll actually use the robotic clip applier now often for this, and you can see that it's tied there, and then we'll cut beyond it. And then we're going to do the same thing on the right side now. I often start with the left side. It's a little trickier. Sometimes there's bowel adhesions, and again, the same procedure there. And we're going to go distally, and same thing on this side. And then we've cut the ureter there. Then we'll go posterior, blunt dissection typically. Take it as far apically as you can perform safely. Remember, the rectum is there, and it'll slant a little bit up as you go there. you can see we're going to be down here, but I'll take it a little bit higher. And usually you're just connecting the dots of where are the lines of where the ureter was, where you did your dissection. So here, and we're going to see above us is the seminal vesicle. So we'll stay high and close on that, and you can see the rectum below us. Again, you don't need to go all the way to the apex of the prostate here. And I'm really just kind of going laterally mainly because I'm going to start thinking about where is I'll widen this, my pedicles are going to be. And you can get to the non-venous fascia actually, and you can start to open that. So there, and now we're going to go laterally, go lateral to the medial umbilical ligaments, blunt dissection. You want to maintain the anterior attachments. Don't go too lateral. The iliac vessels are there. In a nerve spare, I'll go, see, so we're not going to come through the medial umbilical, but we're going to go just lateral to it. We're going to stay up in a nerve spare above the endopelvic fascia. So here's our work that we've done back here. So we're just going to go down through that. The first thing, we'll score the peritoneum all the way through. You'll see there will be places right here where we're going to come through at some point the vas and the medial umbilical ligament. Now we've incised the peritoneum, which is the first thing. And then I'll kind of spread here. I want to be a little more careful that I might do in a prostatectomy. There's more neovascularity in cystectomy, so be careful. Don't have to go all the way down to the endopelvic yet. And then here we're going to divide the vas. And then next to the medial umbilical, and we'll come through there. And this will really open that up, and then we're not working in as much of a hole here, and so we can take this all the way down to the endopelvic fascia. Here we're on the right side. Remember, you don't want it too lateral here. I'll do much of this by blunt dissection. And here I zipped ahead, and here's our endopelvic fascia, and I opened it. So this is a non-nerve sparing, and a nerve sparing, remember, it'll protect you from the nerves below. So here you can see the prostate right up here and the kind of prerectal fat. So you can see how it kind of almost aims up, and here's our prostate there. And then when we look at that, you can see there's the laterally there. And then below is so here's our pedicle kind of nicely shown. And then here we're doing the same thing here. I did on the other side. The left side now, again, prostate is there. We've come through, and the pedicle is seen nicely here. The tip of the seminal vesicle. So the jaw of the stapler will go in there. And that's exactly what we'll do here. The stapler, articulating it up. Because again, what I like about the use of the stapler is if you were to get a little bit of the rectum in there, it'll staple below and protect you. And I think it's just quick and an easy way to divide the pedicles here. So here, I think here we go. The staple is dividing it. And then it opens it up, and it's all open there. Usually you just need one. And then off in there, I'll put a Hemalock clip there. That way, if I want to cut, I can cut above this at the level of the prostate. The other benefit is when I come anterior, I can see how far I've gone. And then here we just staple the right side here. I think there, saw the pedicle, and the same procedure. And then we, on the right side, and now when we look underneath here, we really have the bladder completely freed posterior with the two staple lines here. And here's that Hemalock clip. And I mentioned here securing the stapler is rapid. Watch the rectum below you. Now here we're coming anterior. So this is like dropping the bladder, so to speak, on a prostatectomy. And here we've opened the endopelvic fascia. I'm going to move ahead with this. Oh, this is the stapler part. We've seen this. And then the anterior is similar to prostatectomy. Now we've come over the top there. So now we're at the apex, and you can see it's much more mobile than in a prostatectomy because obviously we freed up the bladder attachments. And then so this is all familiar to everybody. You've taken the dorsal vein stitch and ligating it, and then we'll come through distally, apically. And then I'm going to try to come around this here and get underneath, and I'm going to really work hard to isolate the urethra, And then by doing this, what I like about this is you can avoid complete spillage. So we have the catheter in here, and then we'll remove the catheter and be able to put a hemolock clip. So here you see, I think the catheter, you're going to see it come out. We've deflated the balloon. We have it circumferentially. So here's you might have been able to see the catheter coming out right there. And then we can put the hemolock clip on. So there, and we can divide, we do this proximally and distally. And we have the specimen freed. I often will if I don't clip it, we'll use a stitch to close distally. I think this helps with some of the bleeding too that can happen in that area. And then we'll put it in an endo-catch bag. The larger bag works best. And then I'll get it out of the 15 port so I can do my no dissection. I'm going to skip over this. And then females, the steps here. I think this is fairly quick. We're dividing the IP ligament or the ovarian pedicles. And then we'll find the ureter often lies on this peritoneal medial leaflet. And then follow this distally, and then do our hemolock clip, and then cut it distally, and then posterior dissection, and then can dissect. I find if a patient has had a hysterectomy or has not had a hysterectomy, it's a little bit easier because that plane is preserved. And then I'm just going to move through this for the female, the anterior part. Urinary diversion, I use 8 centimeter incision, usually midway. In a neobladder, I'll move it towards the pubis. In a neobladder, I'll often do this anastomosis performed open. I won't redock. I think it's a lot of effort to do that. But what I'll do before I undock is I'll pre-place my posterior urethral stitches because that makes that part much easier. You can see we're doing that here and avoiding redocking. And this is sort of an ileal conduit here, how it looks. And after, you can see the incision's relatively small. This is a patient obviously with a neobladder, another with a neobladder. And here's a patient we did with an intracorporeal diversion, and all done with a neobladder. And we removed the specimen through the vagina. Setting yourself up for success, set specific goals and times, maybe limit yourself to 3 to 4 hours for the robotic portion. And then if it takes longer, convert to open at that point, maybe do the cystectomy robotically and lymph node dissection open. Measure your outcomes, internal, external benchmarks, lymph node yield, margin rates, assess successes and failure, the technique, discuss with others, patient selection, watch a video. I think this is the most valuable, and never compromise the oncologic principles of this operation. I do want to, this is, I'm going to move this along. This is an intracorporeal diversion here that we've done. And we've done the bowel work here. And I just did one on Friday, and then here you can do the anastomosis. We'll often do the anastomosis now with a Wallace, where both ureters are in front of us. I think you have great magnification of that. And I want to show here, this is obviously a single port kind of device. This is a diagram, and I recently did a single port robotic cystectomy recently and worked out very well as well. I'm happy to take any questions anybody might have. My email is raj.pruthi@ucsf.org, and I would welcome any questions anybody might ever have for me, and I'm happy to help in any way. Thank you. Let me stop sharing my screen. Thank you, everyone, for including me in the meeting.
Dr. Kulkarni, sir. Excellent talk, sir. Dr. Kulkarni will be addressing you. He is the president of the Society of Genitourinary Oncology, sir.
Dr. Raj, it was a wonderful presentation. We are all waiting for you. Thank you very much for sharing your videos as well as your thoughts on this. And we appreciate this taking time off in the morning from San Francisco. So, well, I do not know, are there any questions? If there are no questions, maybe, are there any questions?
Yes, technically, which is the most difficult step to master, sir, in this overall intracorporeal ileal conduit on your bladder? What is the specific step you think you took the longest to master?
In an intracorporeal diversion, I think the most challenging for me was the stapling of the bowel and the bowel reanastomosis. Just because it's a perspective looking at it that we're not used to doing, right? We're not used to seeing. When I use and I kind of move through the intracorporeal part, because I'll tell you one comment about that is, I think robotic cystectomy has a clear benefit. The intracorporeal diversion, I'm not as convinced, especially for a neobladder, that the effort and the time you're putting the patient under adds that much benefit. But the bowel, like measuring the bowel, I'll often take an 8-inch or a 20-centimeter silk suture in order to measure my bowel length, because it's hard to understand, like what looks like long bowel isn't long enough because of the magnification. So, and then making sure when you staple that you're not skiving your staplers, that you're perpendicular to the bowel, aiming towards the root of the mesentery. So those are just things that I found, like at first, I checked and double checked and triple checked. Besides that, I think the ureteroenteric anastomosis is actually easier. It's just about getting yourself set up and getting a consistent pattern of how to do that, if that makes sense.
But don't you think that intracorporeal diversion is quite beneficial for female? If you remove the specimen from vagina, so in those cases, they will not have at least a small scar even on the abdomen.
Yeah, I agree. I think that's the picture I showed you is a neobladder where we extracted the specimen in the posterior vagina to avoid overlapping suture lines. I agree, but I think you bring up a question, though. For me, it's primarily a body self-image or an aesthetic type of issue of a smaller incision. If you're going to have an ileal conduit anyway, I mean, the incisions that we use are 7 to 8 centimeters with extracorporeal. So I'm not saying that it's not necessarily better, but I think that's a second level. You master robotic cystectomy. That's where the true benefit from blood loss and everything and pain even comes from. And there's a little bit of a benefit, I think, in intracorporeal.
Raj, I have one question. Suppose you have a single port robot and then you do a transperineal cystectomy, and I saw the video from Cleveland. What is your opinion on that?
A perineal cystectomy?
Perineal prostatectomy.
No, not cystectomy.
Cystectomy.
Just using single port robot. I thought there was a video came from Cleveland. And I don't know what is your experience on that, or what is your opinion on that?
Yeah, I don't have an experience on it, to be honest. I haven't done that. I've only done it transperineal because I try to mimic robotically what I did open for all the principles. And then the single port, I just copied what I did multi-port. So I don't do transperineal approaches to anything. So I'm just not personally comfortable with it. So I haven't tried open robotic in any way or single port. Perhaps it is better, but I remember when I was a medical student at Duke University, and David Paulson was the chair of surgery and did a lot of perineal prostatectomies.
Perineal prostatectomy, yes.
And those patients, when you saw them after, They may have not had an incision, but they couldn't sit down for 3 years. Well, maybe not 3 years, but they couldn't sit down for a long time. It was painful in its own way.
Would you consider a cystectomy for a second primary after a radical prostatectomy, say 15 years ago, come back with a bladder cancer, now it requires a cystectomy? Would you use a robotic, or would you be comfortable with open?
Yeah, when I have patients who've had, I think that's the most challenging case. Radiation for so we see those patients who've had prostate cancer before, not uncommonly, radiation and surgery. I find the patients who've had prior surgery to be the most challenging, because that plane is completely scarred, right? Gone. And then the hardest are surgery and then salvage radiation. Those are, and I will do those open. I've had one rectal injury, and it was in a patient like that. So maybe I'm a little bit robotically, and maybe that's my anecdotal concern. But I think having tactile feedback may be a benefit to know the planes. I think if they've just had radiation for prostate cancer, so if they've had surgery, I'll do it open, sir, Dr. Kulkarni. If they've had radiation, I'll do it robotically.
Okay.
Because I think that plane is preserved.
Sir, how about the ureteroenteric anastomosis in the initial, when you start up the program? Because ureter generally we handle it so delicately when doing the open job. But these are all heavy instruments we see crushing sometimes, these robotic instruments. So how comfortable and how are the problems of the stenosis or leak and all those issues, sir?
Yeah, I think if you ask me what is really, we talked about intracorporeal diversion. I think the benefit of intracorporeal diversion, if there's one, is maybe cosmetics or aesthetics. But the real benefit might be we don't dissect out the ureters as much. Because I showed you in that picture, right? The bowel and the ureters hanging outside the body. So it's good for meeting, right? But look what we're doing. But you worry that, I personally think ureteroenteric strictures, number one, are very underreported. Second, they're very difficult to manage. We all know this, who deal with this. They're very difficult to manage. Reoperations are difficult. They live with stents. And I think, and I don't think it's monocryl or vicryl, what suture you use. I don't think any of that matters. I think it's the vascular supply to the distal ureter, as you say, Dr. Sharma. And there's a couple of things. Even open, I no longer will, as a routine, tunnel my left ureter to the right side. If there's tension on it, I don't do that anymore because I'm more worried about tension and devascularizing the left ureter. In ureteroenteric strictures, 70% of strictures happen on the left side. It's because we bring that over underneath. So, I mean, I agree with you in everything you say. I don't know crush injury to that, but I do think sewing robotically in the magnification, you do a very good job robotically. But most importantly is you do that ureteroenteric anastomosis much more towards the retroperitoneum, right? You don't need to mobilize the ureters as much. They don't need to come outside the body with that. So I think if nobody's ever shown that, but I bet you in time we'll find that there's less. My guess is we'll find less ureteroenteric strictures with an intracorporeal diversion.
Thank you, sir. Thank you very much for giving this opportunity and for being with us, sir, on a Sunday holiday and so early in the morning, sir. We'll move on to the next session, sir. You stay with us if possible because we have some excellent speakers ahead and we have some case-based discussions also. So I'll ask
Sorry? I just wanted to apologize for being late. I had the timing.
No problem,
I
sir.
thought it was 6 o'clock, but I'm sorry about that.
We figured it out. It was too early for you.
No, it's the time difference is always.
Yeah. It was a pleasure, sir, and there were a good number of audiences were there, sir. We'll move on to the next speaker. You can invite the next speaker.
No, I will ask Dr. Saurabh Patil, my co-moderator, to take the session forward. So Saurabh will carry on forward.
Yeah, sure.
So Saurabh, please.
Yeah, thanks, Indranil. Next, we have two contesting and distinguished speakers with us who need no introduction. First, I would like to invite Dr. Sanjay Adla from Hyderabad, who will be speaking on salvage cystectomy. Dr. Sanjay, sir. Am I audible, Dr. Rakesh?
No, I'm audible. I'm just trying to
audible.
open
Yes,
it.
Sanjay.
Right. Welcome, Dr. Sanjay.
My presentation.
Any issues, Sanjay?
No, the end. Okay. Fine. Thank you very much. It's visible, isn't it?
No, it's not visible.
Okay, I'll share. Okay. Thank you. Okay.
Yeah, it's visible.
So salvage cystectomy, when and whom. I chose this background just to remind us how we used to have normal life before the COVID. And I've added two more things, how and what. So I've been given the topic of when and whom, and I thought I will add how and what. Answering the first question, when and whom. Anybody, we have listened to the talk from Dr. Chilkuri. A patient has had a successful radiotherapy to the bladder, most probably associated as a chemoradiotherapy. Why do we follow up these patients? Because they have got a local recurrence, they might have a lymph node recurrence, or they might have a systemic recurrence. And also we got to be assessing their bladder function. This is better off done with a questionnaire, ICIQ questionnaire, or quality of life questionnaire, just for us to be sure that these patients are not suffering in silence. I'm just going to talk about the first three, which are the local, lymph node, and systemic recurrences. What about the difference between the local recurrence and the systemic recurrence? This was the Massachusetts General, which looked at 475. This was, I think, a combination of almost 3 or 4 RTOG trials. And what they showed is, between this study period of 86 to 2013, 475 patients, these patients do tend to, around a third of these patients tend to have a non-muscle invasive bladder cancer. Around 20% have muscle invasive bladder cancer, and around 35% of them have systemic disease. So whenever I hear a radiologist, radiation oncologist saying that post radiotherapy, they have only systemic disease, at least from this, one of the premier institutions of the world, it suggests that these patients do have local recurrences, and we got to keep an eye out. And only 35% of the patients tend to have a metastatic disease when they recur. Local recurrences, what are these and when do these happen? I have included 2 studies, again the Massachusetts General as well as from the Christie Hospital, which has been quoted before. So from the first date of radical radiotherapy to the date of salvage cystectomy, if you looked at the median time, it tends to be 1.3 to 1.6 years. So in essence, it tends to happen early. 50% will need immediate salvage. So the first rigid cystoscopy and biopsy that is done after the radiotherapy is very important for us to know whether they have had a response or not. 75% of the salvage happen within 3 years. So if you had a close follow-up in the first 3 years, you would pick up 3/4 of these patients, and 90% within 5 years. So all the intensive follow-up is mainly in the first 5 years. After that, rarely do they recur. Okay, and whenever we don't have evidence, we have consensus, and what they are asking us to do is look for distant recurrence. In addition to CT scan, these patients also need assessment of the urothelium, more often in the early stages, and then it becomes 6 monthly, and then it becomes yearly. Okay, so this is from the salvage cystectomy series, which we looked at in Christie Hospital. These were 244 patients. And what I wanted to emphasize is when these patients have undergone salvage cystectomy, around 30% of them have superficial disease, around 10 have T0, in that they had resection of the bladder tumor. So 30% of salvage cystectomy patients have superficial disease. The reason why I'm emphasizing on that is quite often I see radiation oncologists or anybody just following up a post radiotherapy patient with ultrasound scan. And to say that ultrasound scan will pick up even superficial cancer, no, it doesn't. So ultrasound scan in itself is not sufficient. Even if you add on a cytology to it, it isn't sufficient enough. They need regular surveillance cystoscopy and biopsy. Whenever we don't have any evidence, we look at what has been done in the trial. There are lots of RTOG trials looking up not as a follow-up, but they have used this as the follow-up regimen. So a cystoscopy and urine cytology, 3 monthly in the first year, 4 monthly in the second year, 6 monthly from 3 to 5 years. By now, you would have picked up 90% of the recurrences. That's why it becomes yearly after 5 years. So these patients do need regular surveillance cystoscopy. And for the 3rd and 6th month, even if it looks normal, because it could be CIS, better off do biopsy. If these are negative, the follow-up cystoscopies don't need a biopsy, but the first 3 months and 6 months should have a biopsy. The cross-sectional imaging, CT, contrast, chest, abdomen, and pelvis, 6 monthly, it's more by consensus. There isn't any standard way of radiological imaging of these patients. So answering the first question, when then these patients tend to recur 75% within 3 years, rare after 5 years, whom salvage cystectomy, we tend to do it in these, around 2/3 of the patients who have non-muscle invasive bladder cancer, and a third, if you include small volume lymph node, a third who have MIBC. So these are the patients who will be eligible for salvage cystectomy. How and what? How means how to do it. What are the outcomes when we do a salvage cystectomy? When I started my urology career, this was one of the prominent papers we discussed, mainly because it came from our region, Yorkshire of England. And this was what was the evidence in real life. What I meant by real life is when surgeons do 4 or 5 cystectomies a year, when cancer is not centralized, what tend to be the outcome? Because whenever we quote a paper, we tend to quote from premier institutions of the world who do just radical cystectomies for their life. And of course, their outcomes will be good. So this was a first view into what happens in real life. And what they showed is 2/3 or 3/4 of the patients who have muscle invasive bladder cancer tend to have radiotherapy. Only a third, a fourth will have radical cystectomy as a curative treatment. Then the second one was more startling. 3 months mortality, 1/5 of the patients who undergo salvage cystectomy die. 14.5% of the radical cystectomy patients die. And bowel leak is almost triple when you do it in salvage cystectomy compared to primary cystectomy. I was working in Yorkshire, the West Yorkshire and East Yorkshire, and we looked at this data and thought, how can we improve or how can we decrease the complication rate? First, at the same time, Labour came into government, so they centralized the cancer services. So we started doing more of these surgeries. Appropriate patient selection is important. All patients who have recurrence, they would not be fit enough to be undergoing surgery. Rigid cystoscopy and EUA is important mainly to assess the rectum, whether it is very adherent, in which case you will be ending up with more complications. And if during the ileal conduit, which is the most complicated part, not with respect to the technical detail of the surgery, all the complications of radical cystectomy tend to be from the diversion element of it, or the major complications tend to be from the diversion, not from the excisional part. So ureters, take them as high as possible. Small bowel, do not take the dependent part. Take it again as high as possible. Just assess whether this has been irradiated or not. And EROS protocol, yes, can be applied, and minimal invasive surgery, yes, can be applied. Neobladder can be offered in appropriate patients. So following that, we had 2 papers published from the same cohort. So between 1970 to 2005, 846 patients who underwent radical cystectomy, 650 of them who had bladder tumor. And when you look at decadal reoperation rate, we could see that we were getting better. And then the second, when we looked at the 30-day and 60-day mortality, we were getting better. And that was, if you see the last one, which was following centralization, when we were doing more and more of radical cystectomies, we were getting better with respect to mortality rates as well. What about, those were the overall cystectomies? What about salvage cystectomy, which is the main thing that this has been quoted by Santosh, but in a reverse way. I'll just quote it hopefully in the right way. So 420 salvage radical cystectomies to 426 primary radical cystectomy. The objective of this paper was to show that the complications of salvage are equivalent to primary, not the other way around. So when you look at the complication rate, all of them are similar. If you look at hemorrhage, anastomotically, wound dehiscence, urinary, they are all similar when you do either primary or salvage. So the previous impression that when you do a salvage radical cystectomy, patient most probably will die and they might be lucky if they survive is not true. And when you look at the 30-day and 60-day mortality, again, with improvement in the surgical technique, with our improvement in the overall, as Raval sir has said, looking after of these patients, we could prevent mortality, 30-day and 60-day mortalities. Okay. And the last thing, which is very important, is numbers matter. This is from our center. When you look at it, these are per decade. So they were doing about 20 cystectomies per year. Following centralization, in 5 years, we did the same number as we were doing in a decade. So suddenly we were doing around 35 to 40 cystectomies a year. And that's what improved our survival. And when you look at the EAU 2020 guidelines, what they say is, perform at least 10 radical cystectomies, preferably more than 20 radical cystectomies per hospital per year. They are the centers which are high volume. They are the centers which are better equipped. They are the centers that will deliver better outcomes. Select experienced centers, not specific technique, whether it is minimal invasive surgery or open surgery. The surgeon and the center is the key, not the technique they use. Thank you very much. I've answered the question when, whom, how, and what. And the outcomes are good. There was a slide that was missing. There's a 50% 10-year cancer-specific survival following salvage radical cystectomy. So we got to be choosing our patients right. Then we'll be able to control the outcomes. Thank you very much.
Thank you very much, Sanjay sir. It was a very insightful talk. As of now, there are no questions. I think you have cleared all the doubts. So we'll move on to our next speaker. I welcome Dr. Vedang Murthy sir from Tata Memorial Hospital. He will be speaking on role of adjuvant RT. Over to you, Vedang sir.
Hi, good evening, and thank you for the invitation. I hope everything is fine. You can hear and see. You can hear me?
Yes, sir. Very well.
All right. So moving along, I have about 8 minutes to answer. I'll try to answer 4 questions about this topic. Why bother? Can we identify patients who are likely to benefit with adjuvant RT? Can we treat safely? And actually, does it help the patient by improving the outcomes? So let's start with the first one. I think everybody in this audience experts and the delegates will agree that for locally advanced bladder cancer, we've seen this, the outcomes even after adding chemotherapy to cystectomy remain much to be desired. And once there is a relapse, you can see here, the 1 year survival is about 30% and 2 years survival is a dismal less than 20%. So something clearly needs to be done. A lot is being done in terms of systemic therapy with immunotherapy and all these new things that are coming along, and we are talking about it. But what is also being tried on the side, and that does not have that much traction yet, is improving loco-regional control with adjuvant radiotherapy. And this is not a new concept. It was developed in the 80s. It was thought about in the 80s, but things went horribly wrong for the entire field because you can see here small studies, 20, 30, 40 patients, severe toxicity rates ranged from 50 to 70%, and this was completely unacceptable, and it kind of died a natural death. But there were problems, and as has been spoken by previous speakers and Dr. Raval also mentioned, techniques have clearly improved from what it was in the 80s and 90s and even the last 10 years. There was a thought that adjuvant radiotherapy should be reevaluated, and we had written about this a long back, more than a decade back, in 2007 when I just joined the hospital. That look, there seems to be a biological rationale to treat these patients with adjuvant radiotherapy, the bladder cancer, but it's not taken up. And maybe with the improved techniques, it's about time to we look at this again. So that is the rationale. And so can we really identify patients who are most likely to benefit with this kind of treatment? There are a number of studies, number of institutes that have looked at risk factors that affect loco-regional control, and this is a systematic review of many studies. Basically, a number of factors, primarily T stage, nodal stage, margin positivity, and the number of lymph nodes removed, determine the loco-regional increased incidence of loco-regional relapse, which is the patient radiotherapy is likely to benefit. This is a risk stratification from University of Pennsylvania. This is the most well documented and well quoted study. There's a few hundred cystectomy patients. Those who have a T less than or equal to T2 are considered at low risk with about an 8% chance of loco-regional recurrence, that is a pelvic recurrence. Those with T3 or higher are divided into intermediate and high risk based on whether the margin positivity is there. So if margins are negative and nodes, a lot of nodes are removed here, more than 10, the chance is about 20%. And if margin is positive and nodes excised are fewer, then it is high risk, so-called, at 40% chance of pelvic relapse after cystectomy. Now, I'm very happy to share this, and Gagan might have shown this in his talk previously. This is our own data. This is in press, and I'm very thankful to Dr. Bakshi, Gagan, and Mahendra for sharing this. So we looked at 188 patients with TCCs who were all TCCs, no squamouses. There was no neoadjuvant treatment given radiotherapy. About 30% overall had a relapse over the median follow-up of about 5 years, which is expected. Interestingly, 31 patients, so 16% of these patients had a loco-regional component in their relapse. So that is the area that we are targeting. And what we did some modeling and came up with a risk grouping of our own. And this is not yet published. You can see low, intermediate, and high risk based on T2, T3 or T4, N0, N1, N2 or N3, and lymphovascular invasion negative or positive. So the low risk group are patients who have T2 and node negative and LVI negative. And high risk patients are the ones that we are really worried about. Exactly about 35% of patients had a loco-regional relapse, T3, T4, N3 and LVI positive, and everybody else fell in the intermediate risk range. So this is a very interesting information, and this high risk is the one that is likely to benefit. Can we treat safely with radiotherapy? I think all of you would agree that things have changed. You do not see the side effects that we used to see in the 80s and 90s. This is what happens when we treat with a standard conformal 3-dimensional radiotherapy. When the bladder is not there, a whole lot of bowel comes into the pelvis, and it's very difficult to treat the nodes without toxicity. But in brief, this is what IMRT does. You've all heard about IMRT, and this has kind of changed the way we practice things. So can we use IMRT to treat adjuvant radiotherapy? So a lot of people got together, and to make everybody's life easier, we developed this consensus contouring guidelines for adjuvant radiotherapy after cystectomy, what to contour, what not to contour. I'm not going to bore you with all that. So there is now a standard way of contouring and doing the radiotherapy for most radiation oncologists. Finally, is it effective? Well, NCCN seems to think so. Now, these things are kind of coming into the guidelines, slowly creeping into the guidelines, which means there is a story behind this. And I'm going to tell you what this is. You can see here, adjuvant radiotherapy now is, there is category 2B evidence. So where does this come from? This was way back in the 90s when Dr. Zogler from Egypt, they looked at post-op RT versus observation. Most patients had SCC, and this is where the evidence for adjuvant RT in SCC comes from. There was an improvement in overall survival when radiotherapy was given in these patients. So this established radiotherapy in squamous cell carcinoma, which is the standard of care for high-risk features. But TCCs was a different matter. This was a large, not large, but a reasonably sized 150 odd patients phase 2 trial of adding radiotherapy to surgery and chemotherapy. And more than half of the patients were TCCs. And again, you can see an improvement in loco-regional disease-free survival and disease-free survival with adding RT. And there was 11% improvement in overall survival, but this was just not powered for the same thing. And based on this, the guidelines have kind of changed. And
Last 1 minute. Sorry to interrupt.
Yeah, I'm very happy to share with this ongoing trial that we are doing at the Tata Memorial Hospital. Many of you have heard about this. I have spoken to many of you. This is a randomized trial, which will hopefully in the next 4 or 5 years, where we are recruiting slowly and we're looking for other centers. So if you're interested, let me know. So standard treatment, standard arm is cystectomy with some form of systemic therapy, chemotherapy. And the experimental arm is adding IMRT to the pelvis and the cystectomy bed. So we are at about 65, 70 patients now. So I'm looking forward to completing this trial, and hopefully we'll have an answer very soon. And this probably will affect the guidelines as well. To conclude, there is a significant loco-regional relapse in patients who have a cystectomy, especially the high-risk group like T3, N+, less nodes dissected, margin positive, and when chemo is not given. And IMRT, I think, clearly has made it possible to treat with adjuvant radiotherapy now. Thank you so much.
Thank you so much, Vedant sir, for this detailed overview. Now I request Dr. Yuraja sir and Dr. Ginil sir to give their expert comments. We are already running, I think, 30 minutes late. So we'll directly go to expert comment.
Can you hear?
Yes, sir, loud and clear.
So regarding the 2 start talks, I don't want to comment because we are not the experts to comment on that. 2 points I want to highlight is about one comment Dr. Sudhir Raval has made. One is the thing is the patient decision, patient choice is the paramount factor based on which we have to select the diversion, and we should not compromise on this one. We can only guide the patient to select appropriate for him. We cannot compromise his selection based on our intention to do a radical cystectomy by robotic route or laparoscopic route. It should have the right importance. Another point I want to highlight from Dr. Raj Pruti's talk is about the equation of value divided by cost, because I don't think that is very important in present-day practice. And second point is about the learning curve. If a person without proper experience is doing this surgery in a robotic route, he can make the equation upside down, and the cost will not equate with the value. So we should consider all the factors before we attempt for this proper treatment. Then regarding the debate, Santosh and Srinivas has done an excellent job. Santosh was telling why he is concerned about doing a blood preservation protocol. Srinivas was telling why he should get patients for blood preservation. But as a surgeon, it's the right time to think of, because blood preservation has got adequate data, and we have to consider this in our armamentarium. It is a good option. But being a surgeon, we have to consider a few facts. When we are doing a TRBT, even if there is a doubt of muscle invasive, we have to attempt for a complete resection, because even though Srinivas showed that even with the partial resection, we can have a good response with the blood preservation. If the patient is selecting a blood preservation protocol, the patient should have a good survival only if he is having complete resection if possible. So we have to attempt. We cannot leave the part of the tumor. That is one thing, because patient may be selecting a blood preservation. And patient selection and patient counseling is very important. I usually see a lot of patients who had selected for bladder preservation just left alone without any follow-up, without any cystoscopy. This should not happen. It should be properly executed if you are doing a bladder preservation. Otherwise the result will be very bad. So we should have a proper follow-up, as Dr. Sanjay has rightly told. We should have a proper follow-up in these patients who had done a blood preservation, and we should counsel the patient about the chance of not having a neobladder if you had underwent a bladder preservation. You should be aware of that if he is selecting for a bladder preservation, but finally it is his choice. Regarding excellent talk by Sanjay, he had compiled all the important points, and most important points I want to highlight in his talk is the importance of patient selection. Second is centralization. Unless we have got large volume, we cannot have the good data he is projecting. So we should have a centralization. More experienced person has to do the surgery. Regarding adjuvant radiation, Vedang is the best person to talk about that, because I feel that there may be a role for adjuvant, because we are giving a neoadjuvant chemotherapy, and the patient, if you have got a multimodality, only what we have left is adjuvant. If you are having all this spectrum, we may be having the best result in the highest stage of disease. These are the comments I have on this topic. Thank you very much. Yuvraj.
Yeah. Hi, Gideon. So I think everything has been covered now. I think we are short of time. So only one point, especially when we go into the trimodality treatment, we know that it's a very important mode of treatment nowadays for select patients. But however, there is no head-to-head comparison. So the radiation oncologists are doing their own way, and we are doing on our own way. So unless the big centers, so so-called high-volume centers, don't come out with a randomized trials, it's very difficult to accept as level 1 evidence and start practicing in all patients. And although we have only few studies, and another thing is that salvage surgery, of course, so salvage surgery, it has been told, and we have also done many cases, but all of us surgeons agree, although we get the data in a non-randomized way, that there is no difference in complications. But personally, I don't agree with that. So we have a lot of complications, even in high volume center, it's not like that, low volume center. So we have to be very careful. You cannot just treat like any patient who is not undergone radiation therapy. No, we have to be very careful in these patients. I think with these two brief comments, I think we can go ahead with the next talk. So because time is very short now.
So
yeah, thank you, Gideon sir. Thank you, Raja sir. Dr. Rakesh.
Thank you, Saurabh and Indranil, for we move on to the session 4, and I invite Dr. Ashwin Giridhar and Mahendra Pal to moderate this session. Over to you, Dr. Ashwin and Dr. Mahendra.
Thank you, Dr. Rakesh and SOGO, to give us the opportunity. So now, not wasting more time, session 4, we would like to invite Dr. Sudhir Rawal sir for the talk. He is the only few names in India who doesn't need any introduction. So I think just doing a topic, he's going to talk on management of MIBC in octogenarians.
Jiten will speak. Mahendra, actually,
okay.
Because I spoke already, so this topic will be taken by Jiten.
Okay, sure. Jiten, can you take over?
Am I well audible?
Yes.
Okay. I hope you can all see my screen well. So I work with, I'm Dr. Jiten, I'm a consultant uro-oncologist in Rajiv Gandhi, and I work with Dr. Rawal, who is one of the senior most uro-oncologists we have in the country, and that gives me a unique opportunity to have access to 2+ decades of high volume clinical data. So whatever I'm going to here is going to reflect that. So my talk will be divided into 2 parts. First, I'll be talking about the rationale behind cystectomy in the octogenarian population, and then the next part will be about basically going to the nitty-gritties of it. So this topic is going to get more and more important in the coming years. Why? Because we are getting older with each passing year. Our average age that we have, our population is getting older, and our life expectancy is increasing linearly, and we are now catching up with the West. Although we are still young as a whole, but then this is changing with each passing year. And with a decade of SEER database analysis, we have seen that people who are older at diagnosis, they tend to get discriminated against, in the sense that they do not get offered a curative radical cystectomy as often as they should have been. And despite knowing very well that overall survival is better with patients who undergo radical cystectomy. So important thing to understand is that age is not a risk factor for mortality. This is very important. In any multivariate analysis, age does not come. The factors that actually matter in the elderly are frailty, comorbidities, performance status, nourishment status or sarcopenia, stage of disease, and then of course the personal preferences. So just because someone is older, we tend to see clinicians get biased towards trimodal therapy. And there is data, yes, to show that trimodal therapy is equivalent to radical cystectomy for a select subgroup of patients. But we should get some concepts very, very clear. Trimodal therapy is not a palliative treatment option. So before I discuss this meta-analysis comparing outcomes between RC and TMT, the aim behind trimodal therapy is cure. It is a competitive modality to radical cystectomy. So there are very specific indications and contraindications to TMT. So if you have got a unifocal T2 disease with complete TURBT done and absent of arterial, these are the patients who would actually do very well. But the moment you begin stretching these indications, you don't get as good results. And if you actually look at strict criteria, only 6 to 16% patients in your practice would qualify for trimodal therapy per se. And this is the reason why in community practice, when I sit in the OPD, I often see patients who violate TMT protocol. So they would be elderly who would be offered TURBT, then CTRT, and then they would be lost to follow up. And then many years later, they come back with disease, while they should have been on cystoscopic surveillance. So if you actually correctly follow the TMT protocol, the cost will escalate beyond the cost of radical cystectomy. So protocol for TMT is not for every center. You should have the correct center and the correct patient to be offered this modality. Now coming back to the meta-analysis, if you look at in terms of DFS and OS, the picture is the same. In individual series in centers of excellence, you have evidence to see that TMT and RC have got same OS. But when you go to population-based data, where you see people going with extended indications or not so ideal patients and setup, the data overwhelmingly favors radical cystectomy. So even in the conclusion of the meta-analysis, they say that there is a high risk of bias, although in population-based studies, but RC is better. But in correctly chosen patients, you can achieve 90% 5 years for cancer-specific survival. So let's now come to the nitty-gritties of cystectomy. How do we do it? So as already well explained by Sanjay sir, the experience of the center matters. So the more high volume center, the better it is. So this was data presented in International Brazilian Journal of Urology, where they looked at Brazilian data. So mortality in hospital mortality can vary for radical cystectomy vary from 0.5 to 14%. So now imagine the same situation going towards elderly. Here again, in good quality centers, high volume centers, the mortality statistics are actually acceptable. They are within 4 or 5%. But the moment you go towards community center, low volume centers, they again go higher. So this was our own data published way back in 2012. We published a series of 11 patients, and actually the oldest patient in our series is more than 100 plus years old. The complications were mostly minor. There was only one mortality that too happened 1 month after discharge. So now let's come to the actual crux of the matter. How do we select the patient? Now this is very often, not as much taught in medical school as it should be. People tend to confuse the concepts of disability, comorbidity, and frailty. And we must learn to individually recognize them. Comorbidities we understand, disease states. Disability is physical or mental impairment that limits activities of life. Now, frailty is an entirely different concept. This happens because you have the physiologic reserves of multiple systems going down. So these patients, they look, quite good from outside, but the moment a stress is put on them, that is when they actually decompensate. Now, these are all three independent, but their spectrum can overlap, such that 21.5% patients in a usual elderly population would have all three together. And then they cause, the frailty syndrome, which I'll come to. So to look at frailty, you have to look at specific things. So the things that you look are weight loss, weakness, poor endurance or exhaustion, and then they are slow to walk. They just walk very, very slow, and they have low activity levels. And that, all these components are independently important. So when you have weight loss, you have low activity, which is low speed, more muscle loss, more weight loss, decreased strength. And that is when you develop the frailty syndrome, in which, you put in a stressor and the patient just decompensate, doesn't come forward. So pre-fail, put a stressor, he comes back to normal frailty, he goes a bit decompensated but can survive. There can be a state where nobody comes back. So to a clinician, my advice is that, it has been seen that various components of frailty develop in a sequence. So weakness is usually the first thing that develops, and you should, develop a eye for it. Look for weakness in your patients as the first sign, and you will see that by the time they report exhaustion and weight loss, they are actually quite advanced in their trail towards frailty. So these are red signs. So if you have to look for specific sign, I would say look for grip strength. That is the single most important sign. So finally, this is what EAU suggests, to look in the frail elderly patients. You have to screen them for these issues. So they recommend G8 and Minicox scores. And then you group them into healthy versus frail with reversible problems versus frail with irreversible problems and terminal illness, and the treatment options change. So if you have got healthy and frail with reversible problems, give them treatment which you would give to a young patient. Do not, discriminate against them. But the moment you have got severe comorbidities, irreversible frailty, which is, too high score, then change the aim. Now here we are not talking about curative treatment. TMT is a curative treatment. Even TMT is not a good choice for these patients. These patients should actually be pushed towards palliative care. ICUD recommends the same assessment with the G8 questionnaire and classify them vulnerable, optimize them, frail, then put them towards system-oriented palliative therapy.
1 minute remains. Please.
Yes, so these are the final keys to success in an octogenarian. Make sure you have the experience, make sure you have the expertise and proficiency, you're doing a good number of cystectomies, assess frailty, optimize these patients, do not be biased against NSET, manage their nutritional needs, manage their anemia, optimize comorbidities. Lymphadenectomy up to you, omit, don't omit, but for palliative treatment, omit, but for if you're aiming cure, please do it. And you can, limit the morbidity of surgery by doing ureterostomy. And this is our technique, what we prefer. We tend to bring both ureters to the one side. But then there is data to show you can even keep them to either sides, and patients do not really suffer from a bad QOL. Because for them, issues in QOL are entirely different. So in the post-operative period, make them ambulate early, use ERAS protocols judicially. Now I know people have a big fan following for early ambulation, which is good. Early feeding, which I have seen in elderly patients, some patients actually don't do well with early feeding. Look for gastroparesis, look for other issues. Don't feed them early just because you have to follow ERAS. You can tailor ERAS also. Use chest physiotherapy, yes, don't forget thromboprophylaxis, but then remember to switch to palliation early if things are going that way. So in summary, age is not a disease. Elderly actually need more nuanced consideration of multiple issues, and frailty, disability and comorbidities are not same. We tend to think this guy has no heart disease, he's good candidate. No. Look at other aspects of him. Can he hold grip hand? Can he be walking? Can he do his activities of daily? Those things. And given correct treatment, outcomes in elderly are same as those in younger people. Thank you.
So thank you, Jitin. If there is no question, we go for the next speaker. The next speaker for us is Dr. N. Raghavan. He is a consultant neuro-oncologist and robotic surgeon at Apollo, Chennai. And he's speaking on management of non-urethral variants of muscle-invasive bladder cancer. Sir, over to you, sir.
Thank you all. I really appreciate the opportunity given for me to talk on this topic. Management of non-urothelial variants of muscle-invasive bladder cancer. So, this is the WHO classification on bladder tumor. As it is very exhaustive, we'll just skip the slide and move to the basic concepts. As surgeons, we understand only simple things. We don't understand complexities. So bladder tumor can be epithelial or non-epithelial. Epithelial tumors are urothelial tumors or non-urothelial tumors. In the non-epithelial section, we have mesenchymal tumors and other tumors as well. Within the non-urothelial tumors, we have squame, we have adeno, we have neuroendocrine. And within the mesenchymal tumors, we have sarcoma and inflammatory tumors, Others include lymphomas, melanocytic tumors, and others. So that is much better than the WHO classification, isn't it? Just to show that. Yeah. So that's an easy way to remember where we are. Now, in a non-urothelial variant, we have, we know that pure urothelial cancers compromise 95% of the bladder tumors, 5 to 10% compromise in other variants as well. Generally, they are associated with poor prognosis. But if you pick them early and treat them appropriately, we can give them a good survival. Squamous cell carcinoma, it's usually we talk about pure squamous cell carcinoma, not squamous differentiation of a TCC. This can be well, moderately, or poorly differentiated tumor. It's the most common non-urothelial tumor. It accounts for nearly 3% of all the bladder cancers. It can be related to schistosomiasis or non-schistosomiasis. In this part of the world, we do not find schistosomiasis that common. The schistosomiasis related ones are common in the 5th decade versus the one which we find is in the 7th decade. They have a much higher incidence of nodal involvement versus our nodal involvement is low. The interesting difference is that the schistosomiasis related bladder tumors are many times a low grade versus we get high grade disease. The risk factors include a huge list of it that includes chronic irritation to the bladder. It's an aggressive disease, many times locally advanced at the time of presentation. Early diagnosis and local control are paramount. Radical cystectomy, lymph node dissection is the standard of care. 5-year survival is 40 to 50%. Tumor stage is the most important predictor of the outcome, and many times there is a local failure. There is no proven role of adjuvant chemotherapy, if at all, neoadjuvant or adjuvant chemotherapy, if at all, you can try ifosfamide and paclitaxel. Preoperative radiation can be useful, or perioperative or postoperative. It may reduce the local recurrence but does not affect the overall survival of these patients. Next is adenocarcinomas. It can be a primary or secondary. Primary can be urachal or a non-urachal adenocarcinoma, and the secondary is arising from colon, prostate, endometrium, other things. The most key is that whenever you get an adenocarcinoma, always look out for other sites, namely the colon especially and endometrium, before you jump into a primary adenocarcinoma of the bladder. Adenocarcinoma of the bladder is usually invasive cancer with glandular features, but urachal cancers also have very similar appearance. Urachal cancer, we all know, arises in the dome of the bladder. Inevitably, it is rooting itself into the residual urachal component as well. The risk factors for that is intestinal metaplasia, especially in patients with extrophy or a patient who had a bladder augmentation, chronic irritation and obstruction, a bladder diverticular, and because of the stasis of the carcinogen. Whenever I get a cystitis cystica et glandularis, I always feel it is pre-malignant, even though I don't have a strong proof for that. In the non-urachal adenocarcinoma, the tumor stage at the initial diagnosis is usually advanced, older, male patient, high-grade tumors. Sadly, radical cystectomy and pelvic node dissection is the standard of care. It's not a very good prognostic tumor, but if you match it from stage to stage, grade to grade, you may have a similar outcome of urothelial tumors, but keep in mind, many times these are present in elderly patients and therefore they don't do that well. The urachal carcinoma, on the other hand, occurs in the younger patients. Equal male and female distribution, develops from the urachal remnant and presence in the bladder dome. You will find a bladder urachal remnant and you will be able to resect it and prove it. Inevitably, we'll run past some immunohistochemistry just for the proof of it as well. Partial cystectomy is acceptable for these patients. It includes en bloc resection of the urachus, umbilicus, as well as the nodes as well. Now, the key here is to keep in mind that if you have an advanced cancer metastatic to the nodes, they don't do well at all, whereas the early disease usually do reasonably well. In the adenocarcinoma section, non-urachal section, there is no clear role of neoadjuvant or adjuvant chemotherapy. We can give gemcitabine 5-FU if there is recurrence, but it is decided on a case-to-case basis. Neuroendocrine tumor, very rare. I had the joy of having 3 cases this year, but usually you get 1 case in many, many years. The well-differentiated neuroendocrine tumor are limited. They have a very limited ATPR, often small in size, and they have excellent prognosis. But the large cell and the small cell do not have that good a prognosis. Very rare to find this. Smoking is an important risk factor, predominantly male. Whenever you get a TRBT specimen with some neuroendocrine differentiation, always go ahead and consider this as a neuroendocrine tumor. Confirm it with further immunohistochemistry. Neuroendocrine tumor, definitely chemotherapy is the main stay of the treatment. Proper neoadjuvant chemotherapy gives excellent downstaging. This includes etoposide and cisplatin-based treatment. And then after that, if you have residual disease, you can combine with neoadjuvant, with the radical cystectomy. Radiation is offered purely for local control. Bladder sarcomas, extremely rare, usually happens in younger patients, very aggressive tumors. 50% are leiomyosarcomas, 20 are rhabdomyosarcomas, and you have the other rare varieties as well. Inevitably present as hematuria, large tumors. You have to consider an en-bloc resection and a multimodal therapy with doxorubicin ifosfamide. Very poor prognosis for these patients. I had the opportunity of dealing with a couple of patients with lymphoma, very rare. When you do a TRBT, you find a solid tumor and it cuts like a cake. You consider this as a lymphoma. It can be part of the MALT as well, mucosa-associated lymphoid tissue. Excellent prognosis, usually consists of chemo and radiation. Inflammatory fluid tumors can happen, especially myofibroblastic tumors and pseudosarcomatous tumor. Very difficult to differentiate the benign and sarcomatous component to it. Complete tumor resection and close observation, but consider radical or partial cystectomy if you really believe that there is a sarcomatous component to it. Melanoma, extremely rare. I haven't seen one as well. These are the references for this presentation. Thank you very much for the opportunity. I hope I have finished in time. Thank you so much.
Yes, sir. Definitely finished exactly on time, and thank you for in-depth information about the non-lethal cancer. So I would like to invite our next speaker, Dr. Amit Joshi. He is the professor in medical oncology in Tata Memorial Hospital, and he's very interested in uro-oncological cancers. So Dr. Amit Joshi, sir, please take over. He'll give a talk on adjuvant chemotherapy or immunotherapy in invasive bladder cancer. Amit Joshi, sir, please. Amit, sir? We can't hear you.
Needs to unmute.
Sir, please unmute yourself. Dr. Amit Joshi, sir?
Akshita, you can unmute. Dr. Amit Joshi. Akshita, from the organizing side, can you unmute Amit Joshi?
Oh.
Yeah.
Am I audible?
Yeah, sir, you're audible now, sir.
My slides are visible?
Your slides are visible, sir.
Okay, sorry. So my today's talk is adjuvant chemotherapy in bladder cancer. So I think the topic is a little bit difficult to cover, but I have tried to get some data regarding the benefit of adjuvant chemotherapy in bladder cancer. So I think this is very well introduced by other speakers that locally advanced bladder cancer is a systemic disease, and 50% of the patient will have a recurrence within 2 years, and majority of them may have a systemic recurrence. And both neoadjuvant and adjuvant chemotherapy is widely used to decrease this chance of recurrence. And MVAC, DDMVAC, or CISGEM are the most commonly used chemotherapy in this region. So I think the data for the neoadjuvant chemotherapy is quite well established, and there is absolute 5% survival advantage with the EBC meta-analysis that the neoadjuvant chemotherapy even before this surgery has a clear-cut survival advantage. But if we come to the real-world practice, this is a practice pattern which has been collected in the US and presented in GUSCO 2019. And if you see the pattern of neoadjuvant chemotherapy in different stages of the cancer, the blue one is the dark blue one is the T2, the green one is T3 and T4. So even in that part of the world, majority of the patient even still is not able to get the neoadjuvant chemotherapy, which is supposed to be the standard of care. So even in T2, T3, T4, approximately 50% of the patient will get neoadjuvant chemotherapy, which is supposed to be the standard of care. So what are the reasons for that? So if we look into the detail, around 40% of the patient with muscle invasive bladder cancer are ineligible for cisplatin-based chemotherapy. And the most common reason are their creatinine clearance, which is less than 60 ml per minute. The other most common reason which you find is the patient performance status, which is less than 2. So in the real world, when the reason for this was found, it was seen that the majority of as the age advances, the creatinine clearance decreases, and the majority of the patients are not able to get the neoadjuvant chemotherapy, which is supposed to be the standard of care. So if we compare the neoadjuvant and adjuvant, the neoadjuvant and adjuvant has its own advantage and disadvantage. The adjuvant that treats only the highest risk of the patient, and the benefit of adjuvant that there is no delay in the local treatment. Patient gets surgery, and then as per the histopathology report, they get the treatment. The problem with the adjuvant is the evidence is weaker compared to the neoadjuvant, and there is a delay in healing which may preclude giving chemotherapy compared to the neoadjuvant, which might have benefit in terms of clearing the micrometastatic disease, and it has a better level of evidence compared to the adjuvant chemotherapy. So coming to the data of adjuvant chemotherapy, so there are multiple trials which have done, and the first trial which was reported in early 90s is the Skinner trial, which has 91 patients and included both T3 and T4 patient, and the patient received the cisplatin, doxorubicin or cyclophosphamide as a adjuvant compared to the observation in the standard arm. And this trial has shown that there is a benefit in terms of adjuvant chemotherapy with a significant p-value. But there were some critical views on this paper that some patient might not have received the standard of care. Then the other trial which came in the 1995 is the Stock et al., which has also used the cystectomy, the standard arm, and the other arm was cystectomy followed by MVAC. And this trial was terminated early, but whatever the patient accrued at that point of time, so there's significant benefit in terms of survival. And even the long-term data of this trial has shown that the benefit of adjuvant chemotherapy persisted even on the long-term follow-up. But there are other 4 trials which are negative, but these are all trials for a small number, and the trial have included the heterogeneous population, used only a single agent of chemotherapy. So that means there is some data which shows that benefit of adjuvant chemotherapy is there, but with the heterogeneity of the data and the type of chemotherapy which is used, the benefit was not consistent. So these which I have discussed earlier. Then comes there are 2 or 3 meta-analyses which have been done to know the exact benefit of adjuvant chemotherapy. This was a Cochrane collaboration in 2006. This has pulled 491 patients, but this has a limited power, and this has shown that the in terms of adjuvant chemotherapy in whatever the limited patient was around 9%. Then came this paper in 2005, which has the adjuvant chemotherapy for invasive bladder cancer. It was published in 2013, and this trial included the 945 patients with a 9 randomized controlled trial. And this trial has shown that the overall survival in the pool of all 945 patients, but the hazard ratio was of 0.77 for the overall survival, and the disease-free survival was for the benefit was around 0.66, and the disease-free survival was more apparent among those with patients with positive nodal involvement. So this 9 trial of 945 patients definitely shows that there is benefit in the overall survival and DFS also. So then recently there is another meta-analysis which has looked into the role of adjuvant chemotherapy in locally advanced, that means the patient who has a nodal involvement. In previous meta-analysis, all patients of T2, T3 along with the nodal involvement patient were taken. So in this meta-analysis, they only took the patient who have a locally advanced disease with nodal involvement. And this trial mainly the inclusion criteria fitted into the fourth trial. That means the patient with some sort of nodal involvement. So if you see the benefit of adjuvant chemotherapy in patients who have a local regionally advanced disease, the benefit of adjuvant chemotherapy. So there is a clear-cut benefit in terms of PFS with hazard ratio of 0.448 that favors the adjuvant chemotherapy. Similarly, the overall survival was also favored in terms of the hazard ratio of 0.63 in the adjuvant chemotherapy arm. So the meta-analysis of this trial, they concluded that the adjuvant chemotherapy may provide a benefit in PFS and OS with locally advanced muscle invasive bladder cancer who received adjuvant chemotherapy compared to those who patient underwent surgery alone. And these really had also further reiterated that the patient with a nodal involvement may benefit more. So,
2 minutes remaining, please.
Yes. So, the other next thing which is coming into the immunotherapy, which is the next big game changer, and it has already established its role in the metastatic setting. So, this is a very recent updated phase 3 randomized placebo-controlled trial of a patient who received initial neoadjuvant chemotherapy, followed by surgery, followed by observation in one arm or placebo in one arm, and the other arm was the nivolumab. And this has already, the data, the company has released its press release that this data is positive. They are in the next coming conference, they will update the data. So the nivolumab has shown a significant improvement in DFS versus placebo at the adjuvant chemotherapy for patients with high risk muscle invasive in a phase 3 trial. So I think in next year we will get the full data, and this may become one of the standard of care in patient any adjuvant therapy after initial neoadjuvant, followed by surgery, followed by the adjuvant immunotherapy. The other two trials for the immunotherapy, the pembrolizumab and the adalimumab, are already completed the accrual, and we are just waiting for their data to mature. And the other next thing in coming in the next 1 or 2 years, the management of a locally advanced or the of a bladder cancer is going to be based on the specific gene expression, the luminal versus basal, and the luminal will be further divided into the papillary infiltrated. So the treatment, because the chemotherapy or immunotherapy will work in some type of the tumor and not in all. So this is going to be the next future, that the future treatment of MIBC is going to be based on the specific tumor expression. Coming to the specific guideline, the both EUA, SOGO and NCCL all recommends the adjuvant chemotherapy, especially in patients who have not received neoadjuvant. So the benefit of adjuvant chemotherapy should be considered in those patients, and DD-MVAC or gemcitabine with cisplatin is the standard of chemotherapy. So take home message, although the neoadjuvant chemotherapy with cisplatin based therapy is preferred over adjuvant therapy, but the adjuvant chemotherapy should be considered in patients who have not received the initial neoadjuvant chemotherapy, especially in PT3, PT4 and N+ tumor. The magnitude of benefit of adjuvant chemotherapy is more in locally advanced, mostly in the nodal positive disease, compared to the patient who have only muscle invasive bladder cancer. Nivolumab based adjuvant immunotherapy is going to be the next standard of care, and the molecular based selection of perioperative therapy is the way to go ahead in the future. Thank you.
Thank you, sir. Thank you for your extensive talk. Now I take the pleasure to invite Dr. Senthil Rajappa, sir. He's a consultant head Department of Medical Onco at Indomitable Cancer Hospital Research Institute, to speak on recent advances in treatment of metastatic cancer bladder. Sir, you can take over, please.
Thank you, Ashwin. Can you hear me?
Yeah, I can hear you, sir.
Great. Very good. So that's what is happening now. Everybody's taken the back seat. IPL is in the front. Today was a lovely match. In case you're a cricket enthusiast and you missed the match, Ashwin, yes, Ashwin, Sanjay, all of you, SRH lost the super over today. I think that was the first super over in this year's IPL. So we missed that. Looks like we won't have the panel because we are running short of time. So this is going to be your super over as far as today's symposium is concerned. So let's start with something that we know. Cisplatin is better than carboplatin. So gemcitabine and cisplatin is the standard of care for patients with metastatic bladder cancer. Look at these numbers. It's about 14 to 15 months for cisplatin versus 9 months when you use carboplatin. So keep this number in mind, 9 months with carboplatin. Now, if you have a patient who is not eligible for cisplatin, Amit showed you that nearly 40% of patients may not be eligible for cisplatin. One of the things that you can look at in the first line is using immunotherapy. Now, again, there are two rows that are highlighted in this slide. One is the overall response rate, which is 1 in 4 patients who will respond. Now, if you look at the response rates that you get with gemcitabine and carboplatin, it's about 35%. So the response rate is higher with carboplatin. Carboplatin is something that you will use in your patient who is cisplatin ineligible. But when you look at the overall survival, I think that's where immunotherapy scores. Remember, we said 8 to 9 months for carboplatin. But when you use immunotherapy, it's anywhere between a year to 16 months. So the outcome as far as overall survival is better for immunotherapy compared to carboplatin-based chemotherapy for first-line treatment of metastatic urothelial cancer. But I think the story does not end there. If you've got somebody who is cisplatin eligible, straightforward, simple, gemcitabine cisplatin. If you've got somebody who is ineligible, then you need to divide them into 2 groups. Do the PD-L1 testing. We discussed it last time when I spoke about immunotherapy. PD-L1 testing that's positive, they go on to get immunotherapy. But if the PD-L1 is negative, then you get gemcitabine and carboplatin. Now, this is for patients who are cisplatin ineligible. Why is this that you do testing? Because when they looked at the whole group of patients who went on to get immunotherapy, the outcome was worse for patients who did not express PD-L1. So for some reason, you need to use immunotherapy. You have to test, do PD-L1, and then if your patient is positive, the cutoffs are also mentioned on this slide. If you're beyond that cutoff, your patient is a candidate for immunotherapy. Now, I think one study that is certainly practice-changing and has made an impact is this. What did this Javelin study do? They took patients who had either a complete or a partial response or stable disease after a gemcitabine plus platinum. That platinum could be cis or carbo. These patients were then randomized to getting avelumab, which is a PD-L1 inhibitor, till progressive disease, or get only best supportive care. The primary endpoint, remember, is overall survival, not progression-free survival, because that's the appropriate endpoint for a maintenance study. So for patients who are responding or stable, randomize them to immunotherapy versus best supportive care. I think the results are really super. Now, remember, we said 15 months is the overall survival with gemcitabine and cisplatin. Now, this randomization happened when the immunotherapy was started. So for patients who had immunotherapy, from the time that you start immunotherapy, the median overall survival is 21 months. If you add 3 to 4 months of your chemotherapy earlier, it comes to around 25 months. So from 15 months, we are jumping to 25 months for patients who are able to take immunotherapy. Now, your pocket has to be deep, very, very deep, going below the ground if you want to continue till you get progressive disease. If your patient has a PD-L1 that's positive, then that overall survival is still not estimable. So I think that's a practice-changing abstract that was presented this year. What happens when your patient progresses? Because nothing goes on forever. Even if your patients respond well, they will end up progressing. What do you do in the second line? If your patient has had chemotherapy in the first line, then it's immunotherapy. If your patient has had immunotherapy in the first line, it's chemotherapy. Now, bladder cancer is the only area where you have 5 immunotherapy drugs that are approved in the second line setting. I cannot recollect any other subsite in the body where this has happened. So it's like Inky Pinky Ponky, father had a donkey. Which one of these 5 donkeys would you choose in order to treat your patient with immunotherapy? The only randomized evidence is for pembrolizumab. So that's what we usually do when we have a patient. Atizo phase 2 trial, super success, but the phase 3 was a disappointment. The others are all based only on phase 2 studies. So if you decide to do immunotherapy for whatever benefit there is, then it has to be pembrolizumab. Just like Amit spoke about molecular oncology, what we are doing today is to try to see if patients have one of those alterations which will help you choose a targeted therapy. What are we doing in patients with bladder cancer? One of the things that we can look for is what you refer to as the fibroblast growth factor receptor alterations. Now there's 1, there's a 2, there's a 3. You look for alterations in the 2 and 3. What alteration do you look for? You look for a mutation. If you have a mutation and you use adrafitinib, then you get a response of 32%. The progression-free survival is around 5.5 months. The median overall survival for this patient is about 14 months. Remember, we started with 15 months overall survival for newly diagnosed. This is second or third line, and you get an overall survival of about 14 months. So we are slowly and steadily improving. But where is the problem? This is the problem. The price of adrafitinib for a month is $24,752.93 only. So if a patient can afford that, get your test done, and then if your patient is positive, 1 in 5 patients will have a positivity. So what are the reasons? For me, the recent advances, one that's very good, look, Anil and Mukesh want to see you so quickly, is avelumab maintenance for patients who have stable disease, complete response, or a partial response after platinum-containing chemotherapy. That seems to be a super result as far as I am concerned. The second recent advance is if you check for the FGFR mutation in 2 and 3 and use adrafitinib, that's likely to give you benefit in that setting. But I think what all of us need to know is this. As you escort your patient through the journey in metastatic disease, which is very difficult, we need to choose the right therapy and make the right choices, because we don't want our patients to end as Anil Ambani while they started with Mukesh Ambani. So I think we need to be very, very cognizant of what we are doing to our patients. Personalizing therapy is what is important. Thank you so much for that patient hearing, and I hand it over back to the organizers. Thank you so much, Ashwin and Rakesh.
Thank you, sir. Thank you for one of the best talk and the most update talk, as you always do it, even with the peep into a pharma industry also. And thank you, sir. So now I invite our expert panel, Professor Nirmal TJ from CNC Vellore, and Professor SP Singh, the Professor and Head, Department of Urology from PJ Chandigarh.
Hi, good evening, everybody. Am I audible? Hello?
Yes, sir. Yes, sir. You are. Yes, sir.
Yeah. Thank you very much to all the 4 speakers for that very comprehensive and insightful talks. I think Jiten's talk was wonderful. I mean, the key message there was age is just a number and patient selection is key. The only I'd like to put a question to Jiten. I think he touched. It's blasphemous for me to say that I can avoid doing a lymphadenectomy in an octogenarian radical cystectomy. Either Jiten or Dr.
No.
Hello?
Jitin, can you please unmute yourself?
Yes, sorry. The aim of surgery should be clear. If we are aiming for cure, we have decided that the patient is fit for surgery, you do lymphadenectomy. If you are doing surgery for palliation, let's say he's bleeding something else, obviously there is no role of any lymphadenectomy. So I was just talking about literature. There are people who have omitted lymphadenectomy just being that there is an octogenarian population, and they have even gone on to show that survival was not very different, but I disagree. It's just based on scientific principle. Aim is cure, do what is the ideal treatment, just see the fitness aspect.
I think that's a great answer.
I'll add is Nirmal,
Yes,
like he rightly said that many series has omitted the lymphadenectomy. why we got a good result and why we dared to do this before even the robot was with us. We reduced the incision of cystoprostatectomy. That paper got published in 2008 or 2010. We started doing radical cystoprostatectomy with 8 to 10 centimeter extraperitoneal completely. So this actually gave very good recovery to these patients. But we did all ileal conduit and maybe 1 or 2 ureterostomy, but we did always lymphadenectomy in such patients.
Okay, thank you, sir. So one more question to you. I mean, what is your opinion about minimally invasive surgery in octogenarians? Because I've seen recent literature coming, I mean, especially in the laparoscopic age, where they've said that they can get, similar outcomes as open surgery. And because of laparoscopy, decreased blood loss, etc., the patients are better
That's
off.
always better to do with either robot or laparoscopy, or if you are doing open, then you reduce the size of incision. That's perfect.
Thanks. Just one more comment on the second talk by Dr. Raghavan, which was also wonderful talk. I think we have in CMC have an experience of around 50 patients in the last decade where we've offered radical cystectomy for variant urothelial histology. And unfortunately, our survival, like median survival, was only around 17%. Our margin positive rates was unacceptably high. Recurrence-free survival is high. Though complication rates were all similar compared to any other cystectomy, but overall survival, we really couldn't make an impact either with the cystectomy or neoadjuvant therapy. Only 10% of the patients received neoadjuvant therapy. We know that neoadjuvant therapy, especially in variant histology, I think works only for neuroendocrine tumors, doesn't work for anything else. Just wanted to highlight one fact that, I just wanted to highlight one fact before I hand over the baton to Dr. Singh, that I think we have an update of the Pure One study, which in April, which shows that I think pembrolizumab, I think Dr. Sendil can also add to that. I think pembrolizumab has been shown to be very efficacious with squamous cell carcinoma and has shown excellent response in squamous cell carcinoma. That's the only comment I'd like to make. Thank you.
I have very little to add. You're right. The non-urothelial histology do very badly. They always present in advanced stages. And other than neuroendocrine, where we can give neoadjuvant chemotherapy, the rest all doesn't have very poor response to chemotherapy as such, be it in the neoadjuvant or in the adjuvant setting. It's overall a bad disease. That's what we have. And they have very advanced presentation as well.
Professor S.K. Singh, sir.
Yes.
Yeah,
I think Dr. Singh, I would not like to talk much because I have been now handed over the things after 4 hours of continuous sitting. I appreciate all of you. And so myself also, I have been also sitting for 4 hours. So I have not much to add to whatever the speakers and Dr. Nirval had told you. Only one point I would like to highlight is the molecular subtyping. So Dr. Sudhir sir, thank you very much. You are younger than me, 7 years younger to me. That's right. So, but I can see Dr. Kulkarni is not here.
He's left.
Yeah, he has left. But I have not left. I am still there. But similarly, I would like to make a board. So what I will like to make highlight is a molecular subtyping. Now, the people know that chemotherapy will not work, systemic chemotherapy, when PDL1 is positive. The people who have got tumor is positive for PD or PDL1 positivity, they respond less to chemotherapy. Our study also has shown the same thing. But the people who have got the tumor in whom the PDL1 is positive, they respond better to immunotherapy, means checkpoint inhibitor like pembrolizumab and others. So now even the combination therapy is being also tried as a protocol, as a neoadjuvant. Is Dr. Badrinath Konati was talking earlier. Now what he says, the PDL1 positivity has nothing to do with the outcome. Why? Because the people whose tumor is PDL1 negative, they respond better to chemotherapy. And the people who are PDL1 positive, they respond to immunotherapy. So combination works. The chemotherapy works with PDL negative and immunotherapy works or checkpoint inhibitor works for PDL positive tumor. So now maybe that's why there's no difference. But yes, when we have been treating the patient, now in our experience we have seen and in our study, when the PDL positive is there, out of 10, only 1 responded to chemotherapy. Whereas out of 30, the 20 responded to us. 20 responded if the PD-L1 is negative. So response was better, the partial response and complete response. I'm talking of both. So in those cases, the response was better when PDL expression was negative. That is our study, because no studies are available in India. So I thought, why not to do a study, PDL1 expression in patient of Indian scenario, Indian population. So we have done a study. It has been sent for publication. Number is less because cost of that, again, investigation was very high. Yes, so thank you very much. Thank you all. So that was only my comment to make. And I think, yes, I really appreciate all of you. And all of you have decided, I think, to conclude. So I thought, let me at the end, so talk a little bit. I can't again tell you, I have no comment. But yes, all the speakers, they have done their job very well. And they have made my duty very less. That they are expert. I'm just, again, I don't want to repeat whatever they have shown. Thank you very much. Thank you all.
Thank you, S.K. Singh sir and Nirmal sir, for your valuable and very informative suggestions and conclusion.
Thank you, conclude kar do.
Yeah, Dr. Rakesh Sharma.
Yeah.
Rakesh.
Yeah. Thank you, Mahendra and Ashwin, and all the speakers and experts for the session and for the entire program. And I would like to thank Dr. Sudhir Raval sir, JNK sir, and Raghunath, Dr. Raghunath, everybody. Since there is a shortage of time, we are running out of time. It's already beyond 8:30. We have decided to conclude the meeting now, and I would personally like to thank Dr. Raj Pruthi sir and all the speakers who have been involved and put a lot of effort to make this program a successful one. And since the case-based discussions are not happening, probably we will try to complete it at some point of time. As of now, we have decided to keep it on 30th of this month between 6 to 8 p.m. But anyways, if there are any changes, I would personally inform to everybody. For the time being, I would like to ask Sudhir Raval sir to give the concluding remarks for the program.
This is okay, Rakesh, and I'll just say thanks a lot to you and Dr. Raj Pruthi is staying still. Unfortunately, because of the time, we are not conducting case-based discussion. This already we have decided, but we may change the date depending on the availability of everyone and including Raj Pruthi if he can join for this case-based discussion in future. And I'll say that if everything goes fine, we will be having a few talks on urinary diversion per se, for which Dr. Hartman has agreed for 19th November. I hope that goes well, because this time, I don't know how Dr. Hassan has not responded. He's otherwise very good in responding and very punctual. He had been to Delhi and operated in Rajiv Gandhi and Kochi also. So hopefully, let us see, we'll rope in few more people for diversion, but as on today, we will conclude now. And
Dr. Sudhir, I have one hint. Dr. Raj Pruthi want to talk to you. He wanted to respond to your query, whether he would like to join you or not. I can see that he has unmuted.
Yeah, Dr. Raj Pruthi, please.
Helping you. Thank you very much.
Dr. Pruthi.
I'm happy to make it on October 30th.
That's great. That's great.
That's
so
right.
30th October is the next for case-based discussion, just for 1.5 hours.
Right.
Thank you, sir. Thanks. And thanks everyone for staying so
long.
Thank you.
Thank you, Dr. Sudhir. You are always energetic. You fly over
October
sea
30th.
and then still you are operating that.
October 30th is Friday evening.
Friday.
It is Friday.
Bye.
Friday.
Thank you. Bye. Okay.
Bye. Good night to all of you.
Night.
Good night to everybody.
From the elder man from 70, I think, what is that called? The above 60. I'm above 60 now, Dr.
You are still young, Dr. Singh.
Bye. Thank you very much. Bye. Good night. Good night to all of you. Dr. Fuleri, everybody. Bye.
Thank you. Thank you, sir. Thank you.
Bye, Dr. Rakesh. Bye,
Thank you very much.
Always present for the encouragement.